So welcome to our 17th Annual Research Symposium, sponsored by the School of Nursing, Azusa Pacific University, and Sigma Theta Tau. So thank you so much for being here. You are in for a treat. As we have a hybrid meeting today, we are going to have a mix of presentation styles. You're going to have people in person. You're going to have a couple of people sharing via video, as well as when we are done, within 2 weeks, when we upload the Canvas platform, you will have access to 2 more folks that submitted wonderful information. This is Dr. Garcia and Anne Lama, who could not, for unforeseen reasons, be with us today. Their material will be in the Canvas site and on our website, which you will have seen kind of scrolling through the slides. So without further ado, let me bring on our Dean, Dean Lesh. Thank you. Oh. Real quick, some cosmetic things. I forgot the housekeeping kinds of things. So we've got restrooms here, we've got restrooms upstairs. Sorry, men, the majority of them have been deemed women, but we do have a men's upstairs. If there's anything you need to help you feel more comfortable, more welcomed, please let us know, or let the students know they have the white jackets and the red roses on them. Thank you.
Thank you. Thank you, Dr. Smith. And I almost expected her to say, and an oxygen mask will drop from the ceiling, and the exit is this way, and I think, but we have our bearings, and I'm just delighted to welcome all of you, those who are calling in virtually and those who are in the room, to the 17th Annual Research Symposium. It's an amazing opportunity for us to come together in person. I'm just so grateful that we have this opportunity and that we can see each other's faces, that we can welcome each other, and that we can enjoy each other's company, even as we learn and grow in our knowledge of the nursing profession. Nurses have a critical role to play in achieving health equity. The consensus study report, Charting a Path to Achieving Health Equity by the National Academies of Sciences, Engineering, and Medicine on the Future of Nursing in 2020 and 2030, states that a nation cannot fully thrive until everyone, no matter who they are, where they live, or how much money they make, can live their healthiest possible life. And helping people live their healthiest life is and always has been the essential role of nurses. The report continues to say that nurses live and work at the intersection of health, education, and communities. The achievement of health equity in the United States builds on the strengthened nursing capacity and expertise. This is a challenge for our over 3 million nurses in the U.S. today, and it's a challenge for us in the room today. As we look around, we are quick to realize that health equity is intimately tied to what happens at a societal level, about how we share wealth, how we address inequalities, and how we give voice to all. Many of these challenges remain unsolved by leaders in government and business today. But the next 10 years will test the nation's resolve to address these issues and its willingness to provide the necessary resources and the support for nurses to contribute to the creation of an equitable healthcare system and public health system. Nurses have always worked in a variety of settings across the healthcare continuum, and now more than ever, we need them to expand beyond the traditional focus on acute care. Nurses have always practiced at a wide range of professional levels, but now, more than ever, we need to educate them to the highest level and encourage them to practice at the top of their capacities. Finally, now more than ever, nurses need to engage with other healthcare professionals in developing innovative solutions and healthcare redesign. In order to successfully transform care, nurses need to challenge assumptions, engage in joint problem solving, and develop different competencies than they have done in the past. And education, nursing education, will need to embrace a very new paradigm, a paradigm where students and patients are partners in learning and shared creators of knowledge. Today, our presenters will explore ways nurses can assist individuals to truly become a partner in their own health care and to achieve their full health potential. An emphasis on research and statistics, such as will be described in the presentation of all of us, can transform data into information that will dramatically change how we live and how we treat disease. As we start to focus on creating a vision for a more equitable future, it is important to reflect back on the history of our profession and on our core values. Dramatically changing the healthcare environment requires courage and a strong grounding in core principles and values. Despite challenging circumstances and seemingly overwhelming obstacles, God offers words of encouragement and assures us to be courageous and strong as we engage with the task. Joshua 1:9 says, "Have I not commanded thee to be strong? Be courageous and strong. Be strong and of good courage. Do not be afraid, neither be dismayed, for the Lord thy God is with you wherever you go." Today is an important day in developing a foundation for the future of our nursing profession. It is my hope that you will fully engage with our presentations and the knowledge and guidance our presenters will provide for you. And now please join me in welcome Dr. Duke, who will give the invocation.
Good morning. On behalf of the President and the Provost at Azusa Pacific University, it is my privilege to welcome you to the 17th Annual Nursing Symposium. My name is Dr. Bobby Duke. I serve in the Associate Provost role of Faculty Affairs, but this is my 16th year here at APU. So when I see that this has been going on for 17 years, and I feel like I've been here a long time, I realize just how important this research symposium has been and will continue to be. As I thought about these words of greeting, the word that came to my mind was thank you. During my first year at APU, it was during the first spring break, we had to be rushed to Queen of the Valley Hospital where our twins were born. It was during those several weeks in the NICU that I saw how important nurses are for the child being cared for, but also for the families. I looked around to the NICU and realized that all of us who were in there came from very different places in life, different social locations, different ethnic and racial backgrounds, different types of careers. But I watched these nurses go from family to family, from emergency to emergency, and care for us and those with us with the same love and compassion. 5 or 6 years ago, during the baccalaureate for undergrad, I stood on this stage and I said to all the graduates at that time, you will be graduating tomorrow not with just a major, but with a ministry. And when I think of nurses, when I think of APU social work, I could go on and on through the list. We are going to send you out, are sending you out to minister to those around you. Since 2011, my wife and I have been foster parents here in Los Angeles County. During one of the visits that our foster daughter at the time had with her birth family, an hour or so into the visit, we got a frantic phone call that our foster daughter had gone into seizure and was being rushed to whatever local hospital near that freeway that they had to exit. We were quickly, within a couple hours, there with the birth family, sitting there, praying together, crying together, and helping out. But when I walked into that medical facility, they just happened to be the closest one nearby, I realized how different it was from Foothill Community Hospital that our family lives across the street from. I realized that not all hospitals are made the same, not all clinics are made the same, that we do have issues of inequity, we have issues of access, we have issues that this symposium will help to address. I will say that nurses are the bedrock of our healthcare system. Don't tell all of my friends and others, but my wife and I's favorite show right now is called The Midwife. We love that show. But you can see how they weave in the narrative of that show just how much you're dealing not just with a medical condition, but with a person. How these things are all wrapped together. So on behalf of the president, on behalf of the provost, on behalf of everyone at APU and leadership, thank you. Because we know that now you're being trained here at APU, but all of us will need the kinds of service and the love and compassion that you and all of your colleagues in the nursing profession will give. Thank you.
Okay, hi everyone. Oh, sorry. My name is Lily. I'm a senior nursing student. Hi everyone. I'm a senior nursing student here in the traditional undergraduate program, and I am going to be reading a parable, just talking about what it is called, meaning to be called to be a nurse. So those who have their Bibles, I'm going to be reading from Matthew 31 through 46. So when the Son of Man comes in his glory and all the angels with him, he will sit on his glorious throne. All the nations will be gathered before him, and he will separate the people one from another as a shepherd separates the sheep from the goats. He will put the sheep on his right and the goats on his left. Then the king will say to those on his right, "Come, you who are blessed by my Father, take your inheritance, the kingdom prepared for you since the creation of the world. For I was hungry, and you gave me something to eat. I was thirsty, and you gave me something to drink. I was a stranger, and you invited me in. I needed clothes, and you clothed me. I was sick, and you looked after me. I was in prison, and you came to visit me." Then the righteous will answer him, "Lord, when did we see you hungry and feed you, or thirsty and give you something to drink? When did we see you a stranger and invite you in, or needing clothes and clothe you? When did we see you sick or in prison and go to visit you?" The king will reply, "Truly, I tell you, whatever you did for one of the least of these brothers and sisters of mine, you did for me." And then he will say to those on his left, "Depart from me, you who are cursed, into the eternal fire prepared for the devil and his angels. For I was hungry, and you gave me nothing to eat. I was thirsty, and you gave me nothing to drink. I was a stranger, and you did not invite me in. I needed clothes, and you did not clothe me. I was sick and in prison, and you did not look after me." They will also answer, "Lord, when did we see you hungry or thirsty or a stranger or needing clothes or sick or in prison and did not help you?" He will reply, "Truly I tell you, whatever you did not do for one of the least of these, you did not do for me." Then they will go away to eternal punishment, but the righteous to eternal life. So William Barclay comments on this, stating that this is one of the most vivid parables that Jesus ever spoke, and the lesson for nurses is crystal clear that God will judge us in accordance to our reaction to human need. His judgment does not depend on the knowledge that we have amassed, the fame that we have acquired, or the fortune that we have gained, but on the help that we have given. It must be help in the simple things. It must be help with which is uncalculating. Marcia Fowler comments in the Journal of Christian Nursing, Volume 37, Number 2, that serving a neighbor's good reflects the fact that Christians are called to a life of service to God and to others, not simply service to oneself. Exercising one's calling in ways that serve a neighbor's good means not only providing excellent patient care, but looking beyond that immediate nursing context to society and envisioning ways for us to hear our neighbors cry, for fostering the circumstances that would enable them to pursue their own calling. So now I'm going to be talking about Dr. Keith Hall, which will be coming up in shortly. So Dr. Keith Hall is a Middle Tennessee native who started his higher education career in 2001 and joined APU in 2012. As Vice President, Student Belonging, and Chief Diversity Officer at APU, Dr. Hall leads ongoing efforts to cultivate a university culture and climate that enables the diverse demography of faculty, staff, and students at APU to thrive. He remains committed to working collaboratively with academic, administrative, and student leaders to amplify diversity, equity, and inclusion across the university system. So prior to moving to Southern California, Dr. Hall was a psychology instructor at Tennessee State University and a director of multicultural affairs at Lipscomb University. Prior to transitioning to senior leadership, Dr. Hall served as a director of the Noel Strengths Academy and later as the inaugural executive director of APU's Academic Success Center, providing leadership for academic advising, TRIO student support services, TRIO Upward Bound, and student success initiatives. He earned his bachelor's degree in psychology at Middle Tennessee State University, a master's degree in counseling psychology at Tennessee State University, and lastly but not least, and his doctoral degree in organizational leadership at Pepperdine University. So please join me in welcoming Dr. Hall.
So good morning to everyone. Hey, can we thank Lily for the reading of the scripture? And come on, let's give her a round of applause. We appreciate you, Lily. Thank you so much. I tell you, I was talking with Brent Wood. I said, you know, that type of introduction is not necessary. I feel like I need to step up here and maybe preach a little bit, but I promise that will not. Oh, I appreciate the positive reinforcement. Some of you like, go ahead and preach, but that is not my task. I'm here just to pray. But I would like to echo the welcome that Dr. Duke relayed this morning. But I also want to do something just real briefly, and I hope you can help me with this. Hey, can we extend just incredible gratitude to Dean Lesh, to the School of Nursing here at APU for putting on this wonderful research symposium. Come on, let's give them just an applause of appreciation. Thank you so much for your leadership. Isn't it good to be back together? Can I get a yes from the nurses and the aspiring nurses in the place? It's so good to be back. And I can see that you're excited for a wonderful day of learning and inspiration and moments of refreshment. So again, we thank you for joining us, and it's such a delight to be in your company. So if you don't mind, I'm going to ask you to do something a little unconventional. If everybody can just take a stand for a moment. Let's pray together. Let's take a stand. Come on, stretch out your legs just a little bit. Let's pray together. God, we thank you so much for this beautiful day. We thank you for your faithfulness. We thank you for the grace and the mercy that you extend to us. God, I'm so humbled to be in the company of existing and aspiring nursing professionals, advocates of healing, agents of equity and justice. God, I'm just overjoyed to know that I'm in the company of men and women who've been blessed with incredible gifts, strengths, capacity, God, purpose to do the work that they're called to do. Father, I don't take their contributions and service for granted. We know they are agents of healing. And so I pray that this day is a day that energizes them, refreshes them, that it provides moments of refreshment, engagement with colleagues. God, I pray that every person that's here leaves this place inspired and renewed. I pray that they have a clear understanding of what you're calling them to do, and that you affirm them in the service that they render in so many spaces, with so many people, with so many families from a variety of backgrounds, ethnically, racially, socioeconomically, culturally, generationally. Father, they are doing incredible work that just doesn't touch the body, but touches the soul. and changes the spirit of a community. And so, Father, I pray that your favor will rest on this research symposium. I pray that the mission of this institution will be felt throughout this event. God, I pray that there are moments again of relaxation. I pray that you bless every person here with focus and mental acuity, but also moments of laughter and levity, because we need it after the 2 years that we've experienced. And so, Father, we dedicate this experience to you, and we know that you will be faithful and that your love will be felt. Thank you so much for Dr. Lesh. Thank you for the School of Nursing leadership, as well as the faculty. And God, we're so grateful for the students, their enthusiasm, their energy, their excitement for life and for work in the industry. And we dedicate everything that will happen to you this day, and we want you to receive the glory. In Jesus' name, we do pray. Amen. Thank you.
Thank you, Dr. Hall, for gracing us with that beautiful call to God to be with us today. It is my privilege to introduce to you my esteemed colleague. This is Dr. Teresa Dodd-Butera. She is a registered nurse and a board-certified toxicologist. She has worked and has researched on environmental issues that have impacted maternal-child health, as well as children that have special health care needs, as well as concepts that have to do with health equity. She serves many hats in our school. She's the Associate Dean of Research, as well as the Professor of Public Health and Doctoral Programs. Dr. Dodd-Butera.
Thank you, Joy. And thank you to everyone for coming. It is so great to have you all here and our special speakers, both in person and online. So it's with a great honor that I partner with our keynote speaker who's online. And you will be able to see her reflections on health equity. And so I partner with her in this presentation. So as you know, we will be talking about creating a culture of health equity today. So first, let me start off by telling you what my goal is. It's really to help you think about where you fit into health equity. We can define it, we can describe it, but I hope you leave here today thinking about it personally, how you can create it. When we look at the definition of health equity, it means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles, and we'll talk about that, to things like health, for health such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs, with fair pay, quality education and housing, safe environments, and quality health care. So the WHO summarizes this, that health equity is achieved when everyone can attain their full potential for health and well-being. So creating a culture of health equity has a couple of different approaches. I'll talk about the public health approach. The CDC defines the core functions of public health as assessment, policy development, and assurance. They offer 10 essential services under those umbrellas so that we can assure that there is a prepared workforce, like all of you, that we create policies of equity, and that we assess You see how important it was that we were able to do surveillance and epidemiology in the COVID crisis. How about our nursing background? The American Association of Colleges of Nursing has a position statement about diversity, equity, and inclusion that includes improving the quality of education. Education is a great equalizer. Addressing pervasive inequities in healthcare, and nurses and public health professionals are poised to do that. And to enhance the civic readiness and engagement of the potential of nursing students. You will be in positions of leadership. You will be able to speak up and advocate for health equity. So I'm going to talk a little bit about my perspectives on health equity that partner with Dr. Garcia. I have been in a leadership position as the co-director for the Center for Health Equity when I worked at CSU San Bernardino. And I'm the director of the Randall Lewis Health Policy Fellowship. We have some of our fellows here today at Azusa Pacific University. And my theme that I guess I want you to think about carefully today is home. When we personalize our home, the people we love, it becomes clear why we need health equity. So the first thing I've done research in is the first home of every human being, the sacred space of the in utero environment. I have studied acute exposures, things like poisoning and drug overdose, but also chronic exposures in pregnancy and placental toxicology, things like genomics and biomarkers, and conditions of pregnancy and birth outcome from pollutants, lead, cadmium, polyaromatic hydrocarbons. And I've looked at this in obstetric populations in Baja California with Dr. Garcia. I've also done research on environmental threats and emergency preparedness. That's our other home. This is the only place that we know of that can support and sustain human life. This is our collective human home, and it's very important that we think about environmental health equity. There are major religious perspectives about the environment. The Old Testament, Psalm 24:1, the earth is the Lord and all it holds. The Islamic perspective indicates that the environment has its own precise balance. We should maintain it in a fair condition. Pope Francis, the spiritual leader of Catholicism, states concern for the environment thus needs to be joined to a sincere love for our fellow human beings, an unwavering commitment to resolving the problems of society. The Dalai Lama, who is considered a sacred leader in Buddhism, says that many of the Earth's habitats, animals, plants, insects, and even microorganisms that we know as rare may not be known by future generations. We have the capability and the responsibility. We must act before it's too late. So one of the things that I have reflected on and wrote about is the concept of environmental health equity. It's theoretically defined as a set of conditions that are in place for all populations to be equally protected against toxic exposures and to have opportunities for healthful living patterns and outcomes, but that have to be supported by environmental conditions. The only way for the human race to continue is that we can give birth to healthy offspring and that they have an environment to grow and thrive in. The attributes of environmental health equity include an ability to acknowledge environmental conditions impact overall health in populations, that we have an ability to demonstrate readiness to utilize evidence-based practices to change environmental conditions that negatively impact health, and a belief that efforts to change or surmount these negative conditions require commitment to health and tenets of justice that require regional, national, and global efforts. The WHO speaks of air pollution as contamination of the indoor or outdoor environment by any chemical, physical, or biological agent that modifies the natural characteristics of the atmosphere. There are many sources like household combustion devices, motor vehicles, or industrial facilities and forest fires. These are all sources of air pollution. The EPA has criteria pollutants of concern: particulate matter, carbon monoxide, ozone, nitrogen dioxide, and sulfur dioxide. And lead, which is also something I've studied, is noted as a criteria air pollutant. The WHO data show that almost all of the global population, 99% of our human family, breathe air that exceeds the WHO guideline limits and contains high levels of pollutants. This is particularly true in low and middle income countries. They suffer from the highest exposures. Outdoor and indoor air pollution and other diseases can be impacted in terms of respiratory. There's a lot of things we're finding out in terms of morbidity and mortality from air pollution. So in terms of our regional health, let's get back to home. My home is San Diego, which is a border city, and this is where I began my work with Dr. Garcia. Dr. Mara Garcia is a family practice physician in Baja California. She has been my colleague for more than 25 years and a champion of health equity at the US-Mexico border. I want to speak about our research team: Dr. Mara Garcia, Dr. Jenny Quintana, Mercedes Sierra, Carolyn Shaputnik. The reason I say their names is because if we personalize what we do, we remember it. These became my nurse and other discipline scientists that worked with me in a binational effort, who then became my close colleagues, who now we are a group of friends who get together for one another's birthdays. I understand what the environment and health needs to their families and future generations when we think of each other as friends and neighbors. Mara is also an adjunct professor at the Graduate School of Public Health, San Diego State University. She is an educator, evaluator, research scientist, and consultant for the California Office of Binational Border Health and the California Border Health Collaborative. She has been a tireless advocate for maternal-child cardiovascular and respiratory health in vulnerable communities on both sides of the border. And it's really my honor to call her my friend and colleague and serve as partnering with her in this presentation. So what is border health? When we look at defining the US-Mexico border is made up of 10 states and 15 pairs of sister cities, with an estimate of 11 to 15 million residents and approximately 300,000 births annually. The California border region is defined as the area within 100 kilometers, about 62 miles of the US-Mexico border, and it's a unique region in the state of California. Environmental exposures along the US-Mexico border have the potential to adversely affect the maternal-fetal environment. So we have the in utero environment that is impacted by the external environment. Just if anyone's interested, there are 15 sister city plans in Region 9, and San Diego and Tijuana are one of those pairs. We are close neighbors. So even though there are maybe geographic and even political borders, we breathe air together. We need to have clean water together. We are friends and neighbors and family members together. So idling cars and trucks harms the people who live in the border communities. Wait times at the border contribute to the loss of economic productivity. And so we think, how do we create health equity? It's really creating solutions that reduce wait times at the border. This is a picture of when we were doing our study. We actually took, what it looked like to get across the border. We had samples that had to be there within 6 hours from Hospital General, which is in Tijuana. Honestly, without traffic, it's maybe 20, 25 minutes. There were some of our samples that didn't even make it there in 6 hours because there was so much traffic. And so you can imagine just idling, sitting in your cars, but then all the people who live around that area. So our group studied placental biomarkers of PAH exposure and glutathione S transferase biotransformation enzymes in an obstetric population in Tijuana. It was a collaboration of a binational team of researchers. We actually assessed placental biomarkers of environmental exposures in this obstetric population, and the study was conducted on consenting full-term obstetric patients. We looked at placental polyaromatic hydrocarbons, and that they were measured in relation to your GST, or enzyme activity, maternal serum folate, and maternal and umbilical cord blood lead and cadmium levels. This was a picture of the ward there. And so adverse reproductive outcomes have been documented from exposure to PAHs and metals, such as lead and cadmium. And PAHs often are a product of incomplete combustion. And again, there are priority pollutants for the US EPA. Previous birth outcome and experimental studies indicate that exposure to PAHs can act as reproductive toxicants with the potential for fetal loss and compromised fetal development. We have to worry about traffic and exposures on both sides of the border. We do a lot of driving in California. Human studies also demonstrate the effects of PAH exposure on intrauterine growth retardation and neurocognitive development in children. In our univariate analysis, we found that maternal serum folate was inversely correlated with total PAH DNA adducts. Why is that important? Well, what does nutrition have to do with poverty? How do we make sure people get enough to eat? So that not only do you sometimes not choose where you get to live, sometimes you don't get to choose, your situation in life. Poverty, access to healthy food, and we will have some good presentations about that. So our recommendations to create health equity is to further study the role of nutrition. Was there something we could advocate for that detoxifies what you are exposed to mitigate these environmental exposures? It's important, and I want to really emphasize to students, when you do research, an important part of creating health equity is to disseminate your findings, to publish them so other people can find out and know and grow from your work. Our group also attends the San Diego-Tijuana Air Quality Task Force meetings, and we support reducing toxic emissions from industrial sources and vehicles at the border. So the second piece that we think about our home is home safety. As we all know, wildfire smoke, a complex mixture of air pollutants, is unhealthy to breathe, and in California, we are facing increasingly catastrophic wildfire seasons. This affects our own homes and affects California cities that are not even impacted by a fire. If they live downwind of the fire, then they can be exposed to these toxins. So I usually use these sorts of pictures because when you say wildfire, it's one thing. When you see the devastation to people's lives and homes, it becomes quite real how important it is that we are mindful of the conditions that create the opportunity for wildfires and prevent them as much as possible. In addition, equity includes preparing people as much as possible. When we think about particulate matter, I just want to explain to you that wildfire smoke is relatively a short-term exposure, but the particles from the smoke tend to be small. And as all of you know from your physiology, the small particles are what allow when you breathe in, that get to the lower parts of your lungs. And so when you go deep into the lungs, the tiniest ultrafine particles can also pass into your bloodstream. There is an association between PM, or particulate matter 2.5, and heart and lung health effects. This is well documented in the scientific literature. The health problems secondary to wildfire smoke exposure can be mild, like eye and respiratory tract irritation. They can be serious with worsening of heart and lung disease. And if you have health conditions already, they can increasingly aggravate this. And they found that the inflammation that you have in wildfires also increase your susceptibility to COVID-19. In addition, maternal exposure to wildfires, especially during late pregnancy, were linked to reduced birth weight and preterm birth. There is also the trauma and mental health of wildfires and other emergencies. So from today, something you can do to create environmental health equity, I put up some resources that you can download and share. There's mobile devices for Breathe Well from the California Air Resources Board, and my slides are up there. You can always access each day and share with your patients the air quality index. Which patients should need to know about this, particularly respiratory and lung. But again, you are that agent of maybe you know about it, maybe your patients wouldn't know about it, so share that information with them. And so one of the things when we look at wildfires and other emergencies, I had an autism clinic. Some families come to me who knew I was a toxicologist and were wondering about autism. We started talking about a couple of different needs in the community and found out that, in fact, although they were aware of emergencies, weren't quite ready for it. So when we look at the environment, we look at, again, our homes, our first home, our in utero environment, the homes we live in, the state of California, the kinds of things that we're exposed to. We can't help all of that, but you can help create health equity by preparing people. And so vulnerability is a greater determinant of disaster than the hazard themselves. The people who have the least do the worst from environmental disasters. When we talk about families with children with special health care needs, the second group that I am talking about today that I worked with, it is particularly important to advocate before people are born, but even when they're here. There are children with autism spectrum disorder that are very traumatized when you change their routine. There are about 1 in 44 children that have been identified with autism spectrum disorder, according to estimates from CDC's Autism and Developmental Disabilities Monitoring Network. This is important because persons with ASD and fires can't be identified by appearance. They look the same. You may need to give them directions, speak in short, clear phrases. And some persons with ASD may not be able to process clear directions. Some children may be at risk of fleeing when evacuation is taking place. So how did our research team promote equity? Through collaboration, unity of campuses, and community empowerment. Something you'll see in some of the posters today is a creation of what is the Tell One model that I'm challenging all of you here today. It's not enough that you come and you sit in a workshop or a meeting. It's important that you share the information and empower a community. The families that attended our workshops were given extras and told to tell one. They take the Tell One model, they come, they can get all these free things, but they have to take extras and they have to share it. So any knowledge that you take away from today, please tell one. We're going to do, as we finish up, a case study on equity. Here's a family that has special health care needs, employed, insured, work well. This was from my article. They have great difficulty with their child adjusting to routines. But they do have regional centers, they have specialists, so they have some support, and they have providers who provide them care. They live in an area that has plans for environmental emergencies, but they don't have a specialized program for families with children with special health care needs. The state and local health departments don't offer any specialized training for first responders to deal with children with ASD, and there are no designated evacuation centers. Imagine a child with ASD in a busy high school auditorium with they don't have the ability to debrief the way other children do. So the family expresses the need that we have some unique needs. We want some specialized training. We have to designate shelters that can handle children. But the state and regional agencies say, no, it's fine. We are going to have equal opportunities for just like everybody gets the same thing. So we're not denying people who have children with ASD anything, but we're not making any special arrangements for them. I want you to remember that equal is not equitable. So this is from the Robert Wood Johnson Foundation. Equality means you'd give everybody the same thing, be it bicycles, services, but everybody doesn't need the same thing. So you want to level the playing field and make sure that everybody has equal, equitable access. So as I end here, I want you to think about barriers exist in our society for people, that not everyone starts at the same place. I want us to review that definition. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. It is our job in public health and nursing to do our best to advocate to remove those barriers for people. So it's not the end, it's the beginning of all of you to think about and challenge yourselves to how you can create health equity. Listen to all of our speakers today, watch the things online, and be changed by it. Begin to really think of yourselves as change agents for health equity, environmental health equity, all kinds of health equity. Thank you again for coming to our sessions and for allowing me to speak. God bless you. Bye-bye.
Thank you, Dr. Dodd Patera. My name is Joy Pomdara, and I'm the director of the entry-level master's program at the Inland Empire Regional Campus. Our next two speakers are Duyan Kaufman and Adam D'Amico. Duyan Kaufman is a health program specialist with Biomonitoring California at the California Department of Public Health. She has over 20 years of experience working in public and environmental health in the United States and abroad. She has been with Biomonitoring California since 2012, and the focus of her work has been on individual results return, health education, and community engagement. Prior to joining the California Department of Public Health, Duyan worked as a case manager for low-income Latinx and Vietnamese immigrants at the County of Marin's public health clinics. Adam D'Amico is an environmental epidemiologist with Biomonitoring California at the California Department of Public Health. His work has centered on the collection and analysis of biomonitoring surveillance data with a focus in metal and endocrine disruptive chemical exposures. He received his Master's of Public Health from the University of California, Berkeley in 2015. Please join me in welcoming our guests.
California program in the Environmental Health Investigations Branch at the California Department of Public Health. I will be presenting today with my colleague, Adam D'Amico, a research scientist, epidemiologist, and we'll be talking about assessing environmental exposures in California. So the objectives of our presentation today are to give some background on our program, including its foundation, mandate, and goals. We will also define and discuss public health surveillance of environmental chemical exposures through biomonitoring studies, and we will describe the California Regional Exposure Study and present its main findings and how we disseminate those findings to participants, communities, researchers, and other stakeholders. But before I get into more details about our program, I would like to back up a bit and talk about chemical exposures in general. As I'm sure you're all aware, we humans are exposed to chemicals every day, no matter where we are. At home, at work or school, indoors or outside, in urban or rural settings, chemicals are everywhere all around us. This graphic here shows the main sources of human exposure to chemicals. So we have industrial pollution in the air, water, and or soil. Also landfills and waste we produce through our everyday living gets into our environment as well. And then there are consumer products like personal care products, so shampoo and cosmetics, cleaning products, and other things we bring into our homes like furniture, toys, and clothing. And then there's drinking water from wells or public water suppliers, and food, whether fresh or processed, so there's pesticides, preservatives, even food packaging. These are all sources of chemical exposures. And then, of course, there are occupations, and you might think of obvious things like welding or firefighting that would expose workers to chemicals. But even those of us who work in offices or schools are surrounded by plastic and home furniture and stain-resistant carpeting and many other things that contain harmful chemicals that can get into our bodies. So how do we know what is getting into our bodies and at what levels? Well, we can do biomonitoring. Biomonitoring is the science of measuring chemical exposure through laboratory analysis of biological specimens. So usually urine and blood, but studies have also used hair, breast milk, fingernails, and fat tissue. Biomonitoring can help track the types and amounts of chemicals that get into people from all sources combined, and it provides an overall measure of exposure to certain chemicals found in air, water, soil, dust, food, and consumer products. So in recognition of the need to understand chemical exposures in our diverse state with its unique history, geography, climate, industries, demographics, and other factors that may impact our exposures, the Biomonitoring California program was created through legislation in 2006 with the passage of Senate Bill 1379. Our program is a collaboration between CDPH and the Office of Environmental Health Hazard Assessment and the Department of Toxic Substances Control. The primary goal of our founding legislation is to monitor specific environmental chemicals in a representative statewide sample of Californians. The legislation also incorporates the principle of right to know, which is that participants have the right to know what chemicals they have been exposed to. So we do return all individual results to study participants on request, and we ensure that the results are scientifically accurate and understandable, and that any uncertainties inherent in the information are clearly described. And some of you may be aware that the Centers for Disease Control and Prevention, or the CDC, assesses chemical exposures at a nationwide level through its National Health and Examination Survey, or NHANES program, which Adam will talk about more later. And that data is extremely useful, but it cannot be used to assess exposures in individual states. So by measuring chemicals in many people across California and over time, we can learn whether some populations are more exposed to chemicals than others and how exposures to certain chemicals might be changing with time. This information can then be used to assess the effectiveness of public health efforts and regulatory programs to reduce Californians' exposures to harmful chemicals. So biomonitoring a large state like California is very challenging and resource intensive. So to date, our program has done mostly community-based studies where we have focused on particular sectors of the population, usually a population that's particularly vulnerable to chemical exposures. Our first project shown here was the Maternal and Infant Environmental Exposure Project, or MEEP, which studied chemical exposures in mother-infant pairs. So we collected blood and urine samples from pregnant women and cord blood at birth when possible. Shortly after me, also in 2010-11, we conducted the Firefighter Occupational Exposures, or FOX project, and biomonitored 101 firefighters, mostly men, in Southern California. Next was the Biomonitoring Exposure Study, or BEST, a collaboration with Kaiser Permanente in Northern California that recruited Kaiser members from the Central Valley. This was our program's first study to collect samples from participants randomly selected across gender, age, race, ethnicity, and location. And there were 2 phases, pilot BEST in 2012 and expanded BEST in 2013-14. Then, because we knew from our BEST study findings and other biomonitoring studies that Asians have higher exposures of certain chemicals than other race ethnic groups, we conducted the Asian Pacific Islander Community Exposures, or ACE project, in 2 phases. ACE-1, which recruited participants of Chinese descent, mostly from San Francisco, and ACE-2, which recruited participants of Vietnamese descent, mostly from San Jose. This project grew out of our long-term relationship with community-based organizations working with low-income immigrant Asian populations and developing messaging around contaminants in fish from the San Francisco Bay. So most of these early projects I just described measured multiple chemical panels, including metals in blood and urine, per and polyfluoroalkyl substances, or PFASs, in serum, and many other chemicals like phenols, flame retardants, and pesticides, resulting in a lot of information to give to people. So for ACE, after consultation with our community partners, we decided to focus on 4 metals of concern: arsenic, cadmium, mercury, and lead, with potentially high exposures in low-income Asian populations, as well as PFASs, which are chemicals used to make products resistant to oil, stains, grease, and water, because some PFASs had been observed to be higher in some Asian populations and were also chemicals of emerging concern in California. With the CARE study, which was our program's first effort at conducting statewide surveillance, we are continuing this focus on metals with a larger panel of 10 metals, so the same 4 metals as above, plus cobalt, manganese, molybdenum, antimony, thallium, and uranium, and a smaller panel of 12 more commonly detected PFASs. Since some of the other PFASs in our laboratory's larger panel had very low to no detection frequencies in the ACE project. For the CARE study, we also considered regional issues and concerns and measured additional chemicals relevant to particular areas. For example, in Los Angeles County, we measured a chemical found in diesel exhaust. So we're focusing on these 2 groups of chemicals for surveillance because there are known or suspected links to health outcomes from exposures to these chemicals. For 4 of the metals shown here, we have identified levels of concern, and there is sufficient evidence of the health impacts of levels above those levels of concern to warrant participant notification and education. There are also widespread opportunities for exposures to both of these chemical groups across the state, and I'll talk about those a bit more in the next slides, but for more information, you can visit our website at this link to see our chemical fact sheets, which describe what the chemicals are, where they're found, what the possible health effects are, and ways to possibly reduce exposure. And spoiler alert, this might not come as a big surprise, but washing your hands is one of the things we can do on an individual level to reduce our chemical exposures. But there are clearly more upstream issues like chemical policy and use that need to be addressed at a higher level to reduce our exposures to some of these chemicals. And here I'm just showing some potential sources of metals exposures that you will see in our fact sheets. So, for example, many metals like cadmium and lead are used in many industries and products, and rice and seaweed shown here can be sources of arsenic exposures. Here in the middle, I'm showing homemade skin creams purchased in California that contain dangerous levels of mercury. I'll talk more about that later. But some fish can also be high in mercury, especially larger fish like this swordfish here. But we also have a legacy of mercury use from gold mining that has polluted many waterways in California. So people need to be careful about where they're catching and eating fish. And then there's historical use of lead in paint, which was banned in 1978, but any building that was built or painted before then should be assumed to contain lead. So there are strict protocols that should be followed when renovating or repairing older homes. And then, of course, there's drinking water, which I'm sure we have all heard can contain lead, as well as other harmful metals like arsenic. And moving to sources of PFASs, you may have noticed that a few of these images didn't change. So some fish and drinking water can contain PFASs as well, which I mentioned are used to make products resistant to oil stains in water. And since some of them are very persistent, they accumulate in the environment and end up in waterways and fish. PFASs are also found in nonstick cookware, like this rice pot shown here, or these kinds of takeout containers and bakery paper and microwave popcorn bags. And they're also found in furniture and carpeting, either applied during manufacturing to make these products stain resistant, or by consumers who spray these items in shoes and other household goods to protect them from stains. And now I'm going to pass the floor to Adam D'Amico, who will talk about public health surveillance and the CARE study and present some of our metals and PFAS findings.
Thanks, Zwen. So now I want to talk about public health surveillance and how biomonitoring fits into it. So here's a definition of surveillance the CDC uses. The ongoing systematic collection, analysis, and interpretation of health-related data essential to planning, implementation, and evaluation of public health practice. And they go on to specify that this should be closely integrated with the timely dissemination of these data to those responsible for prevention and control. So in other words, surveillance is about the data that we use to understand what's going on right now in order to help make public health decisions. Oops. Okay. So here's a list of some of the uses of surveillance data in general. It can be used to identify patients and their contacts for treatment and intervention, detect epidemics, estimate the magnitude and scope of health problems, measure trends and characterize disease. You can use it to monitor infectious and environmental agents, assess the effectiveness of programs and control measures, and it can help you develop hypotheses and stimulate research. So you can imagine how some of these uses apply to a disease like COVID. Health departments use information about COVID cases to do contact tracing, to monitor case rates, find hotspots, see if things are trending up or down. Surveillance can also be used to monitor things like the prevalence of tobacco use among adolescents. And in the area of environmental health, we can use surveillance to monitor the levels of chemicals in our environment and in our cells. We can evaluate if a particular policy, like banning flame retardants from furniture, is effective at reducing our exposure to those chemicals. So surveillance can come from many different sources. There are many diseases that providers are required to report back to the health department. This includes COVID, but also things like TB, hepatitis, certain STDs. Other sources include hospital records, birth and death certificates, cancer registries, and then surveys where you actually go out and collect data specifically for surveillance. None of these sources is going to be perfect, and every source has its limitations. In the case of COVID, the increased use of home tests might mean that fewer cases are being reported to the health department. No matter what your data source is, you need to be cognizant of its strengths and its weaknesses. So let's take a closer look at some of the uses of biomonitoring surveillance data with this example. So lead used to be commonly used in a lot of industrial applications, in paint, ceramics, batteries, gasoline. And this, particularly leaded gasoline, led to widespread environmental exposure. In the mid-70s, more cars started to use unleaded gasoline, and leaded gasoline was eventually banned in the mid-90s. While modeling data predicted a slow decline in blood lead levels, biomonitoring data collected as part of NHANES shows that blood lead levels actually track very closely with the total lead used in gasoline. This is an example of how modeling might not accurately depict exposures, and also how biomonitoring data can be used to demonstrate the impact of policy. In many ways, the story of lead is a public health success. Environmental and biomonitored levels of lead have continued to drop, but lead testing is still important to help us identify communities and individuals at risk. You've likely heard about Flint, Michigan, and the water contamination there. Flint is unfortunately just one community with lead contamination. Recent testing in California schools has found that many have unacceptable levels of lead in their drinking water. And we know that there's no safe level of lead, so there's plenty more work to be done. So as I've mentioned, a lot of biomonitoring surveillance data comes from surveys. So let's talk about how we design those surveys to be representative of the population. We obviously can't collect blood and urine samples from all 40 million people in California, so we need to take a small sample of those people to represent the state. There are two broad categories of sampling methods. The preferred one is called probabilistic sampling. This type of sampling gives the highest quality statistics. The key feature of probabilistic sampling is that there needs to be random selection from a known population, meaning that you need to have a list of everybody in your population in order to select from. The easiest example of this is a simple random sample. Let's imagine that these 20 people are our study population. If we wrote down all of their names and then put them in a hat and pulled out 5 at random, this would be a simple random sample. In reality, we would never rely on just 5 people to represent a group, but that's the basic process. Now, there's one major drawback to this approach. It requires that the people who are randomly selected actually agree to participate. Nationally, we've seen declining participation rates for many years now. Fewer people are willing to answer the phone and participate in surveys. The more people who refuse to participate, the more you have to worry if your sample is going to be meaningfully different from the population that you're trying to study. We might find that certain demographic groups are far more likely to refuse to participate. And you could ask yourself, could the people who refuse to participate have different levels of chemical exposure? For instance, could they have higher levels of lead for some reason? So this type of sampling takes a lot of work and resources, many phone calls, many attempts to contact people. And in the case of biomonitoring, it requires that you meet them in person to collect blood and urine, no matter the distance. So the other type of sampling is non-probabilistic sampling. This is a much easier thing to implement because it requires no random selection. You don't need to have a list of everyone in your population. But because there's no random selection, it means there's a lot of room for selection bias. There may be different kinds, there's many different kinds of non-probabilistic sampling, the most basic being a convenience sample. So let's say that you want to do a study and you're just on a street corner asking people a series of questions. To be efficient, you ask the first 5 people that you see. Now, are those 5 people going to be representative of everyone in your community? You might ask yourself, what time of day are you doing this? What street corner are you on? Are you in front of a school or a police station? Would your choice of a street corner affect your ability to recruit people of a particular race or a particular gender? It's very likely that your method of selecting people is not going to give you a sample that's representative of everyone. One way to get a better sample in this framework would be to do a quota sample. So you set quotas for specific characteristics like age, race, education, and then you recruit people until you meet those quotas. So this way, even though you can't say for sure that the people in your sample are completely representative of your population, you can say that at least they're similar to the population in regards to those characteristics that you selected your quotas on. So the main source of biomonitoring data at the national level is the CDC's National Health and Nutrition Examination Survey, or NHANES. NHANES uses a complex multi-stage probability sample every 2 years. They randomly select counties, and then within those counties, they randomly select segments, and then randomly select households, and finally, they randomly select individuals. They take these large trailers to each of their selected counties, and that's where they do their examinations, which includes collecting blood and urine. So if you put the data from all of those people together, you get a representative sample of the US population. You can get good, reliable data for the country as a whole, and you can answer questions like, what's the average blood lead level among adults in the US? But the one thing that NHANES can't do is give us answers about the local level. NHANES only visits 15 counties across the US in a year, so they just won't come to enough California counties to have a useful sample of our state. So how do we know what's going on in California? Well, Biomonitor in California was created to answer this specific question. We want to know the magnitude of chemical exposures, how they change over time, and how our policies affect them here in our state. Remember, California is a large, diverse state. We have coasts, forests, deserts, and farmland. We're home to nearly 40 million people from all over the world speaking over 200 different languages. So the trends that we see at the national level may not apply everywhere in California, or to California as a whole. So this leads us to the California Regional Exposure Study, or the CARE study, our first attempt to biomonitor the state as a whole. CARE is a statewide study of metals and other environmental chemicals in adults that we conduct one region at a time. We decided on this approach because of the large size of the state and because it would be difficult to cover the entire state at once. So we aimed for about 300 to 500 people in each region. And we started in 2018 in LA County with CARE LA. And then in 2019, we went to 5 eastern and southeastern counties for CARE 2. And those counties included Mono, Inyo, San Bernardino, Riverside, and Imperial County. We did go to a third region in San Diego and Orange counties in 2020, but that got cut short because of COVID, so I won't be talking about that today. We measured all of our participants for metals and PFAS, and in a subset of people, we measured them for other chemicals. So for the CARE study, we chose to use a quota sample. Based on our resources, we found this was the most feasible approach for us to take. We constructed quotas based on 3 factors: geography, race, ethnicity, and gender. To the right, you'll see a map of LA County. It's broken up into 8 geographic areas. We took those areas and constructed quotas based on the population distribution by race, ethnicity, and by gender, and with the goal of having roughly 500 people in the study. Our primary recruitment method was to send out a postcard broadly. We sent it to tens of thousands of homes. We also posted on Craigslist, on social media, and we worked with community groups. One person that we worked with was Dr. Dodd Butera here at Azusa Pacific. We gave a presentation to her class, and she was able to help us navigate some of the different stakeholders in the area. So let's go into some of the basic steps of the study. I've described recruitment already, how we got our information out to the public. Whoever was interested could fill out an interest form. And on this, we collected basic demographic information, including race and gender, as well as contact info and some preferences for how they'd like to participate in the study. After that, our staff got to work selecting individuals based on our quotas and based on the information people provided in the questionnaire. We sent out invitation packets to our selected participants, and in that packet we requested that they sign a consent form, complete a questionnaire, and schedule an appointment. We wanted to make this easy for everybody to participate, so we offered a few different ways to do so. We could email them a secure link, and they could fill out these forms online. Or we could mail them a paper packet, which they could fill out, mail back, and then give us a call to schedule their appointment. And if they spoke another language that wasn't English or Spanish, then we would reach out to them with an interpreter. So when it came time to the appointment, people would give their blood and urine samples. We offered appointments throughout the region and at different times, including the weekend. Our staff would then process the samples, get them into the freezer, and periodically ship them back up to our lab in the Bay Area. Our laboratory scientists would get to work processing the samples. Now, these aren't clinical tests that we're doing. Our labs use very specialized methods that can detect things at very low levels, and so it could take between 6 to 12 months to get results. And once we did get those results, we would package them all together and send the individual results to our participants. And only after that could we start to look at the data and see what we could learn. So I just wanted to give you a little example of some of the things that we would ask on our questionnaires. So we ask questions about housing, water, diet, occupation, hobbies, tobacco use, and reproductive history. Each of these questions has some relation to at least one of the chemicals that we're studying. So for instance, seafood consumption may help explain differences in mercury or arsenic levels. Now I want to talk just a little bit about some of the challenges that we faced in designing the study. So one of the first challenges is looking at who responds to surveys. So this is a main problem in all non-probability samples. The participants are volunteers. So it's possible that some people respond because they know they've been exposed to something and they want to get measured. We also find that certain demographic groups tend to be easier to recruit. In both studies, the people who were interested in participating tended to be older, more often female, and more often white. We had to do more targeted outreach in order to recruit certain demographic groups and to meet our goals. And to do that, we partnered with community groups. There are other barriers to participate too. Certainly, time and distance are factors. We tried our best to make appointments convenient. We also offered incentives. In KRLA, we offered $20 for each participant. The feedback that we got was that $20 barely covered the time and energy it took to participate, so not really much of an incentive, especially when you're asking people for blood. In CARE 2, we increased the incentive to $50, and we found that our participants were a lot happier with this, and we think this helped us draw a more diverse set of volunteers. And then finally, I want to discuss the challenges of covering a large geographic region. So here's a map of CARE 2. The salmon dots represent population size, and as you can see, most of the population is in one small area. And there's a large swath of desert that is very sparsely populated. We set up our main office in San Bernardino in the populated area, and we set up collection appointments in various locations within 90 minutes of the office. This would give our staff time to drive out, collect the samples for a few hours, and still be able to return to the office to process them. A lot of the population fit in this 90-minute radius, but what about the counties and the population centers that were further away? We ended up creating temporary outposts in Bishop and Brawley, staying overnight, setting up freezers in hotel rooms, and driving back a few days later to the main office. So definitely a challenge. So how representative was CARE really? Here's a breakdown by race and ethnicity and education for the CARE LA sample, as well as LA County as a whole. As you can see, for race and ethnicity, the numbers don't match up perfectly, but they're pretty close. And we would expect this because it was one of the variables that we used for our quota sampling. Education, on the other hand, was not used for selection. And as you can see, our numbers are pretty far apart. Our sample tended to have higher education levels than the county as a whole. And this is just CARE LA data, but the same pattern is true for CARE 2. And this is one of the dangers of quota sampling. You can control the variables that you're sampling on, but there's still a lot of ways your sample may not be representative. Now, since we were able to measure this, and since we know what the population level should be, there's ways to adjust our data so that it's more similar to the population. However, there are certainly going to be unmeasured factors that we just can't adjust for. One last thing that I want to note on this slide, that the state is moving toward a more comprehensive way to display race and ethnicity data, especially when it comes to multiracial identities. And if you want to get an example of this additional breakdown, there's a bonus slide at the end of this presentation that you can download. So here are some of our results. And I'm just going to focus on the 4 metals with levels of concern and some of the more well-studied PFAS. So lead and arsenic were detected in all of our participants, and we found that PFAS, cadmium and mercury, were in nearly all of our participants. So as I said, Our lab techniques can detect very low levels of these chemicals, and you can see that virtually everyone is exposed to them at least a little bit. All these chemicals pose potential health concerns, but for most of them, we lack adequate scientific information to determine what would be a safe level. And so, as Sven said, we identified levels of concern for 4 of the metals, and we do extra follow-up with those people. We had 30 participants in the 2 care regions, across the 2 care regions, with inorganic arsenic levels that were above 20 micrograms per liter. And this represented roughly 6% of the KRLA population and 4% of the CARE2 population. And when it came to blood mercury, the level of concern is 5.8 micrograms per liter for those who are pregnant or may become pregnant, which we defined as adult females less than 50. And we had 15 participants across the 2 care regions in this group who had blood mercury levels above the level of concern. And that represented 3% of that group in KRLA and 9% of that group in CARE2. We can also compare our results across studies. Compared to national levels from NHANES, we found that CARE participants had higher levels of arsenic, higher levels of blood mercury, at least in KRLA, lower levels of lead, and lower levels of 4 commonly detected PFAS. And we can see some clear disparities by race and ethnicity in our data. Asian participants had relatively high levels of certain chemicals. This included arsenic and mercury. They also were high in PFOS, which is one of the older and better studied PFASs. Black participants had blood cadmium levels 45% higher than our white participants in KRLA. And for our Hispanic and Latino participants, we found slightly lower levels of PFOA in KRLA. We found other demographic trends as well. So we found that lead levels increased with age, PFAS levels increased with education. So those who had high school diplomas had PFOA levels 61% higher than those without a high school diploma. And this matches up with some trends that we see nationally. Now, these results that I just shared are just basic demographic associations. We can't say for sure why these differences exist in these groups. This is something we're going to continue to explore, and in future analyses, we plan to look more at the data that we got from the questionnaires. Now I'm going to pass it over back to Sven to talk about how these data help our participants.
Thanks, Adam. Excuse me. Excuse me. As I mentioned earlier, our program returns all results to participants who request them. And some participants do actually opt out, though it is very few. And this is in the form of a hard copy paper packet, which you can see pictured here. And I'll get back to those in a minute. But before that happens, we do have a protocol for following up with participants who have been found to have elevated levels of arsenic, cadmium, mercury, or lead. So participants whose levels exceed any of the levels of concern for these metals are notified and receive personalized follow-up, such as surveys to identify potential sources of their chemical exposure and advice on ways that they might reduce their exposures. In some cases, clinical follow-up is recommended with technical assistance provided as needed. And as for the results packets, these contain the participants' individual results for each chemical measured with comparisons to the overall study results so they can see how they compare to the rest of the participants from their region. And we also provide comparisons to the most recent NHANES data, as Adam discussed earlier. And we provide fact sheets for each chemical or chemical group. And this is just the first step in our results dissemination, that we return individual results to participants before we present the study results publicly in any forum. So after we've done the individual results return, we usually try to organize a community meeting where we invite participants and others from the community, including community partners and organizations, and present the overall study results. This can include written materials like a study summary, which we can also share with community partners and on our website more broadly. We also present the study findings and data at our quarterly scientific guidance panel meetings, which are public meetings that have always had an option to attend virtually. And the next meeting is on July 22nd for those who are interested. We also have an online database where we post our study data, and that's available at our website shown here. And we're currently working on an overall report on the CARE study, which is something between the level of that lay-friendly study summary and scientific manuscripts, which our staff also write to disseminate findings to a larger scientific audience. So I touched on mercury in skin creams earlier, so I'd like to turn back to that now, as I think this illustrates the value of biomonitoring as an important public health function, as well as its value to individual study participants and its relevance to healthcare providers like yourselves. As I mentioned, mercury has been found in some skin creams made outside of the US and sold on the internet or in stores, at flea markets, and through other informal supply chains. These creams are used for skin lightening, for example, on freckles or even the overall skin on the face and neck, particularly by people from cultures or, sorry, I've lost my place, or countries that place a high value on lighter skin. So these creams are used also for wrinkles, acne, and other blemishes. So they can contain very high levels of mercury that have either been included as part of the original formulation of the cream, because mercury is unfortunately an effective skin lightener, or it's added to existing creams, usually locally made or homemade products, but even well-known brands like Pond's have been found to be adulterated with mercury and then resold online or through informal networks. So when people use these creams, they are exposing themselves and other household members to potentially toxic levels of mercury. And if they develop symptoms, their healthcare providers might not recognize them as signs of mercury exposure, since they can be nonspecific. For example, memory loss or irritability, anxiety and depression, headaches, weight loss, fatigue, tremors, and numbness and tingling in the extremities. So we have had study participants identified with high levels of mercury in the biological samples collected for biomonitoring in MEEP, which was that study of pregnant women and infants conducted in 2010-11, and then more recently in the CARE2 study. So in accordance with our protocol, we followed up with these participants, notifying them of their elevated mercury levels and administering a survey that helped us to identify skin creams as their source of exposure. In both cases, we obtained permission to communicate with their healthcare providers who had been unaware of their patients' mercury exposures, and we recommended further testing, including of children and other household members and other clinical follow-up. And you can read the case study of the MEEP participant at the link shown here, including how we conducted an investigation to find out the source of her mercury exposure, which was 2 skin creams purchased at a pharmacy in Mexico that contained 21,000 parts per million and 30,000 parts per million of mercury, respectively. So for context, the Food and Drug Administration standard for mercury in face cream products is less than 1 part per million. So this case and other cases that were occurring across the country at that time led to the FDA into issuing a consumer alert, which is linked here, and also a CDPH health alert to warn people about the existence of these creams and the dangers of using them. In response to this issue, CDPH also developed educational materials about mercury in skin creams for community members and have made these available on the EHIB website with the clickable link shown here provided in our slide deck. This includes a whole section with Spanish language resources, as I should note that both study participants I mentioned above were Spanish speakers, and also fact sheets in other languages like Chinese and Vietnamese, Arabic, and Hindi. We also have information for sellers of skin creams, letting them know that it's illegal to sell them in this country, and we have resources for healthcare providers, including the signs and symptoms of mercury poisoning and guidance on clinical tests and medical management. And lastly, we have a list of face creams containing mercury, all of which have been purchased within California. You can see an example here. So whether over the internet or in person, at a flea market, and this list includes photos and the country of origin of the cream, as well as the locations where they were purchased. So I invite you to check out this resource and familiarize yourselves with the many different kinds of creams that have been identified through our work. And now it's back to Adam to zoom out a bit and wrap things up.
Thanks, Wen. So I'd like to step back and remind us that mercury in skin cream is an example of one source of one chemical, but that every day we come into contact with environmental chemicals in the food that we eat, in the water that we drink, in the air that we breathe. The only way to understand what we're exposed to is to study them. Biomonitoring is a powerful tool for measuring those exposures, and thoughtful surveillance can help us put those measurements into context. And so what's next for biomonitoring in California? We're currently looking into some alternative approaches to do our surveillance work. One potential path forward would be to work with the Genetic Disease Screening Program. This program tests maternal serum samples during pregnancy for certain genetic diseases. And we could get access to some of these samples and test them for environmental contaminants like PFAS and other chemicals that we measure in serum. Other options would include working with a high coverage provider like Kaiser, doing a probabilistic sample, but in a smaller, more manageable area, or possibly collaborating with another group here at the health department to design a surveillance system to measure people for lead and other metals. So if you've got any questions or you want to learn more about biomonitoring California, you can go to biomonitoring.ca.gov. And you're also welcome to email me, Zwen, or our program lead, Narissa Wu. Our first report about the CARE study should be coming out in the next few months. So if you're interested, keep an eye out for that. And before I go, I just want to thank our participants who made the CARE study possible. And I'd also like to thank the organizations that supported us, the other biomonitoring staff, the state and CDC for funding this work. And finally, I want to thank all of you for listening.
Thank you.
Sarah, as well as Dwayne and Adam. That was so thought-provoking. I thought we were going to have a mass exodus out of California. Instead of doing questions right now, let's take a break, come back at 11, take a moment to go up to the exhibitors, look at the posters. We'll see you back.
I'm going to introduce our next speaker, so if we could all take our seats. While you're getting into position, I want to just tell you something that frequently happens when you hear this much information about all of our toxic exposures. You can feel a little overwhelmed. Like, what do I do with all this? We're going to talk about that. We're going to have some tools. Just start thinking about how you can do one thing at a time to create health equity. It's also really important that we as Californians know in all those samples they took that they found lead, that we have exposures to arsenic. It's empowering when you know these things and you can do something about it. So I don't want you to worry. We're going to be talking about different programs that you can be involved with. Please find me if you want to do any research with me. Any of our faculty, we're here to help you. But we're just taking it a little step at a time, so don't feel overwhelmed by it. Okay, our next speaker is the wonderful Dr. Colleen Lenners. She is the Director of Policy at the American Association of Colleges of Nursing, which serves as the national voice of academic nursing. Dr. Lenners was selected as a Robert Wood Johnson Foundation Health Policy Fellow in the office of Senator John Thune. Colleen serves on the board of Friends of the National Institute of Nursing Research, Case Western Reserve Alumni Board, and many committees for the American Association of Nurse Practitioners. She has maintained an active family nurse practitioner practice for over 26 years and has served our country in the U.S. Army Nurse Corps. She has many notable achievements, both civilian and military, including being inducted as a fellow in the American Academy of Nursing and in American Academy of Nurse Practitioners. She was also awarded the Bronze Star for her service overseas. Dr. Lenners received her DNP in leadership from Case Western Reserve University. So please welcome Dr. Lenners. We're so happy to have her.
Good morning or good afternoon, depends on what area you're coming from. Ooh, that's loud. So when I ever get my bio, it always makes me feel like I'm old. What I want everybody to do for me, if you could, is kind of raise your phone and kind of wave at me. We want to tweet you to NIH and the American Association of Colleges of Nursing. This is such a beautiful group. First time we've been in person in a long time, and I want to make sure everybody gets noticed the best we can. There we go. Wonderful. I know we definitely are living in a digital world. So you heard a little bit about me, but what you don't know is I'm actually from this area. I got my AD, my associate degree nurse, from Victor Valley College. How many are here from the high desert? Anybody? Yay! I got my master's degree from the University of San Diego, and believe it or not, one of my instructors is in the audience. I couldn't be more pleased. Hey, two. And it was so nice that we got to come around and I got to be part of Azusa Pacific, because I think it was 2013, I think Patty and I decided, that I was actually an adjunct faculty in clinical in San Diego. So it's like coming home for me, and I want to thank you. So let's talk, am I going the right way with this? While I talk about where this study came from and how I got involved, we're doing research, right? So what do we know about research? There's a pre-survey, which means what? There will be a post-survey after the lecture, so we can find out what we learned, if anything, from this little lecture we're going to have. So while you're doing your bit.ly link there, use your little cell phones to do the bit.ly link, and it'll say AACN pre-survey. From the drop-down menu, choose the American Association of Colleges of Nursing. Why this is important is that NIH uses this information to change this educational lecture if it's not meeting your needs. Now, I have all the lights in my eyes, so it's hard to see. But how many of you are freshmen? Many? Great. A few of you. How about sophomores? Yay! Juniors. Good junior class. Seniors. Seniors always are the most excited because they're leaving soon, right? So we always can tell where seniors are. And mostly because you guys will be taking care of me. So I'm excited about this as we move on. Has everybody gotten to this link? So the All of Us research program started actually with the 21st Century Cures Act, and that happened in 2014. At the time, Joe Biden, who's currently our president, was vice president. And many of you know his son, Beau Biden, who also served overseas in both Afghanistan and Iraq, came back and was diagnosed with a glioblastoma. At that time, Vice President Biden went to President Obama and really talked to him about what was going on. And like any parent, he went around the country trying to find a possible cure for his son or what could be done. And what he found is that there is wonderful research going on across the country, but the data is siloed and we're not sharing it. And I think some of that happens because we know whoever finds the cure for cancer will probably never have to fundraise again, right? They'll have a lot of money. And so they started this program called All of Us Research. So we're going to talk a little bit about that now. So how many of you have heard the term precision medicine, right? Most everybody. They should have heard it by now. It's really an emerging approach for us not to treat a disease-specific area with the same thing that we're giving everyone else. Right now, if you have a certain type of cancer, there's a certain type of chemotherapy you'll get no matter where you are on the spectrum of that cancer. And what we've learned is that no two people are alike, and we really do need to tailor the treatment for specific populations and people. We need to take into account not just their disease, that's one part of them, but we need to take into account how they live, where they live. I thought that was an excellent lecture right before us, right? Excellent. Like, we're looking at California, different areas, and those biosamples. We need to look at not only their environment, but their biology. This is their genomics, their genetics. So we want to take a look at all these factors and not treat people in a one-size-fits-all, but tailor their medical treatment to fit them. We are very fortunate. I understand we have community partners here. Kaiser, if you haven't seen, are certainly way ahead and work with their population on preventative medicine. I actually did some of my early training at Kaiser and worked there. I think this is a great way for the community to come together. So we have precision medicine, and we have for years in real life. If I gave you my glasses, you couldn't see, right? Insulin. Now, we all don't take the same insulin, nor should we. And of course, now at the cost of insulin, we can't. Blood is not the same. We aren't going to give somebody who's AB negative, OPAs. And hearing aids. Believe it or not, have you walked into a patient's room where you hear that, and so it's the hearing aids are not set for the individual people. So we've had some type of precision medicine for a while now. But we really want to hone in at this point in time on the individual person. So what does it cost for us to currently use the imprecise medicine we're using now? I don't know how many of you are NP students out there or working in a system where you have a formulary that you have to use, right? If you're working in a federally qualified health clinic, that you can't necessarily order that patient the best blood pressure medication you would want to for several reasons, but mostly it's cost. So you start with something that will work, that's inexpensive, and it's the beginning. Well, you give the patient the medication, you have them follow up in a month, they're telling you they're taking it, they're changing their lifestyle, but their blood pressure is still too high. So you add another medication. Come back and see you, so now you've got a couple of visits, right? And the patient's having to take time off of work, and you're coming back again. Now you're adding a third blood pressure medication. The patient's blood pressure's still not under control. And what we find is those patients, sometimes who are taking 3 and 4 different medications to come under control, have to choose between whether they're going to eat, pay their light bill, or take their medication. The cost of imprecise medicine costs us all. We really do need to formulate medications and treatments for specific populations. So providers like me and you, do you want to keep seeing your patients back again feeling like you really haven't accomplished anything because you're trying to take care of their medication, you're trying to educate them, you're looking at the patient as a whole, but within your arsenal, within your toolkit, you're limited. So we really want to make sure we're taking care of providers so that they can take care of patients. And let's talk about researchers. You heard the gentleman right before us, right? They had to really try to get study participants. They had to reach out. They had to go into communities. They had to offer monies. And still, they had a biased sample. So I think when we talk more about this research project, you're going to see the utility of it, not just for you or for me or for them, but for all of us. That's what we're hoping for. We want researchers to get what they're doing at the bench plate, what they're studying and working on, to the bedside and to the patient in a much quicker time. And that's going to take a lot of work, and it's going to take trust. And that's something NIH is going to have to work on. So let's meet Ray. Ray is a gentleman who's older, and he feels a little more pain, and he doesn't, getting a little tough to get up and get to work. And then we have Kim, and Kim is a young girl who lives in the city, who eats well and exercises, and she can't remember when they're sick. But both Kim and Ray live in different areas, and they both have something that they can share. They can share their histories, and they can share their genomics. And we're hoping that through different people sharing their information, we will see patterns emerge. We will see some similarities. We will look for different things in both your electronic health records and through your genetics to see if what is environmental and what is actually genetic. And I don't think we know yet. Okay, so these are some of our community provider networks. As you can see, we have the American Colleges of Nursing, American Academy of Family Practice. We have the Y, National Black Nurses Association, the Asian Health Coalition, 50 Forward. These are just some of the organizations that have backed this research. I do want you to know that this was as December 2022. There are more now. December 2020. There are many more organizations now that are involved in this. And I hope you're going to see some of your own area involvement. So if you look at some of the consortium, these are some people that are currently involved. And for this area, we have UC Health, UCSF, UC Davis, San Diego Blood Bank. So these are some different areas that are currently involved with this research project. It's really interesting when I listened to the last presenter about how they could use this database as we move forward. So what is this? This is a program to recruit 1 million Americans across the country, 1 million or more, from different lifestyles, from different states, from different socioeconomic groups. And this is to accelerate healthcare research. As you heard in the last presentation, the gentleman had a hard time recruiting people of color. And there's good reason for that. And we're going to talk a little more about that as we go on. But really, we need to take into account the differences in people as well as what's alike. We need to look at their socioeconomic. We need to look at their biology. We need to look at their environment. We need to look at what medicines they're currently taking or not taking. And I think we really need to look at the patient as a whole. And who does that better than nursing, right? There's a research tape that recently came out about, it was a physician, great physician, and she said, it's really not about the disease or the medicine. She goes, it's really about the social determinants of health. We can work in the emergency room, as I did for many years, and we would see diabetic patients coming back and back and back, and to eventually where they'd have an amputation, where had we just taken care of them, bought them shoes and socks, made sure they had a place to live, it would have been better health care around and probably much more cost effective. So these are the kind of questions that we're really hoping the All of Us research program will answer. Obviously, the one about cancer, that's really how it started in the Cancer Moonshot. What about pain management, chronic pain management, not necessarily acute? Narcotics work very well for acute pain management. The problem is they're only supposed to be for 2 weeks, 3 weeks at the most. How many of you seen patients on Tylenol number 3, Percocet for 20 years. I know I have. We need to look at this and work better at this. We also have dementia medications. How many of you know that there's actually a new dementia medication that FDA is looking to approve? Right. You know why it's not getting approval? Because the only people that took the medication and that they trialed it on were white males, 40 to 60. So you could not take this medication and generalize it. Right now, they're going back, they're increasing the study, they're trying to recruit people to be involved in this study so that the medication can be approved, and the cost will be another issue. So how is all of us different than other research? You saw the last researcher, right, about trying to recruit people by targeting an area, and they were focusing not necessarily on a specific disease, but looking at heavy metals and how it infects you. Well, all of us isn't really looking at any disease. They're looking at you as a person, as an individual. They want you to, decide you want to be a part of this research study, or that your patients do, or that your family does, or that your community does. Again, they're looking to enroll 1 million or more, and that's to help researchers, right? Not go out and try to recruit people. This data bank will be there. They will be participants. That's what your last researcher said. They wanted participants. They wanted people to answer their surveys. So it really makes a difference. We also know, as you heard very clearly in the last study, every ethnic group does not respond to medications or treatments the same as others. And yet, most of our medications and treatments are the same. So we really are trying to target medicines and treatments made for all populations. And we want this to be an engaged community. We want them to fill out their surveys. We want to give them chances to be involved in research if they want their study to be involved. No. This is a very powerful video, and I hope, Teresa, at some point in time you can send it out. But this was Francis Collins, and he is talking to other researchers about how most of the medications were indeed formulated for people that weren't as diverse as our country. We talk about some of the egregious behavior that has been done to people of color, to communities, underserved and underrepresented, the fact that many of these areas don't even have access to care, much less care. They talk about equity, inclusion, and how we really need to be there for everyone. Nurses and nurse practitioners are certainly the healthcare provider in rural and underserved areas, and it's being noticed. At the Centers for Medicare and Medicaid, we know that nurse practitioners are the largest growing Medicare provider in the country. They're taking care of people that are not in areas that have high revenue. So hopefully you'll get to see these videos because they're extremely impactful. Okay, so I'm going to actually read this because I think it's important. Although I hope you guys do get a chance to watch the videos. They are very impactful, and I think they speak, a whole lot to this problem. So why should people participate? Why would anybody participate? Well, today minorities make up 38% of the U.S. population. By 2060, minority populations are projected to rise more than 57% overall. Increasing diversity in biomedical research will enable scientists and researchers to learn more and more over time. Hispanics represent 18.5% of our population and are projected to constitute nearly 30% of the U.S. population by 2060. Yet Hispanics represent only 3.1% of participants in NIH clinical trials. 3.1%. The African American population makes up 13.4% of the U.S. population. Heart disease, end-stage renal disease are some of the leading causes of death. We also know that African Americans between the ages of 18 and 49 are twice as likely to die from heart disease than are whites, and we do not know why. Yet African Americans contribute only 1.6% to NIH clinical trials. Asian Americans, Native Hawaiians, Pacific Islanders make up 6.1% of the US population. They are also the fastest growing racial and ethnic group, yet one of the most understudied. Asian Americans present very differently for diabetes, and they present very differently for cancer. Cancer is the leading cause of death for Asian Americans. This population is supposed to grow by 132% by 2050. For our Native Hawaiians, Pacific Islanders, heart disease is one of the leading causes of death. Less than 0.1% of Asians are actually involved in clinical trials. So do you think the blood pressure medication that I'm prescribing to Mrs. Wen is actually formulated for Mrs. Wen? Probably not. But we're doing the best we have with the knowledge we have. We really need more diversity in our study. Even the last researchers showed it. People's cultural, ethical, ethnic, and geographic regions play a huge part on their health and their health care. And I think we need to be more aware of that. But why don't we have a lot of people of color involved? Well, we have very good reasons, right? There's Henrietta Lacks. How many of you know the story of Henrietta Lacks and the fact that it's her DNA, right? So the Lacks family is still large in Baltimore. There's still issues. The family doesn't even get free health care from Johns Hopkins, actually. We went into the Havasupai tribe, did syphilis trials there. There were dioxin trials on inmates. We all know about Tuskegee and the syphilis trials. There have been egregious abuses done to people, and certainly communities of color or communities that have been underserved under the guise of medical research. NIH is aware of this, and they know that they are going to have to win back the trust of these communities. And they're going to need to do it one person at a time, one community at a time. And you nurses and nursing students are ambassadors. You know that this exists, but it is a personal choice whether people want to be involved. There have also been some good that have come out of this egregious behavior. And we'll talk a little more about that later. But for the participants, it's supposed to improve the health for generations, to increase access to your own data, to learn about additional research, and meet others that are potentially like you. That's the promise for participants. So why am I involved? You know, why am I so personally involved in this? Well, you heard from my bio that I was with the 47th Combat Support Hospital in Tikrit, Iraq. I was there from 2005 to almost 2007. We were down from a burn pit. You did hear about environmental exposures, right? So we were down from a burn pit. When I came back from Iraq, I had a bad cough. It was terrible, but so did the rest of the world that was in Iraq. That land had been cultivated for 2,000 years, right? So I went and got a chest x-ray, and we had a brand new radiologist. His name was Brian, and he was lovely. But he said to me, "Major, I think I see something." And of course I said, "Brian, you're a new radiologist, you're over-reading the film." And so it took him a couple of times. You know, I'm never a good patient. Took him a couple of times. So I finally went and got my chest x-ray, and then I went and saw the oncologist. Because what I had was lymphoma, follicular lymphoma, directly related, or we assume, to the burn pit from Iraq. I went through 5 years of chemotherapy, and currently I'm cancer-free. But these are my children. Staff Sergeant Paul Shiraishi and Shiraishi, currently holding the flag, and my middle son, Daniel Shiraishi. Now, these kids were used at USD for the pediatric training, right? So what we found is the flag that they're holding there is the flag of their father, Japanese Hawaiian, died of adenocarcinoma within 2 weeks of diagnosis. Never smoked a day in his life, lived in Hawaii, known for lovely air and good environment. So now my children have 2 primary parents that have diagnosis of cancer from very different ethnic, very different regional backgrounds. So I think it's important, this study. Not necessarily for me, hopefully for my children, but most importantly, for my grandson. He just turned a year. That's him and his luau. In the Hawaiian culture, they don't celebrate the birth of a baby till they're a year. Anybody here from Hawaii? Yep, so my kids are Hapa. And Henry, or Henri, his father is French-Canadian, is Japanese, Hawaiian, German, French. I don't think they know exactly everything on the French-Canadian side. So very deep gene pool, right? But I want to know that my genetics, or was it environmental exposure? We're assuming it's environmental. And my ex-husband's aren't actually passed down to this child. And this is why I'm so personally involved with this. But everybody has a story. And letting people have access to your electronic health record, or to your DNA, or for you to take surveys, is a very personal decision that everybody has to make on their own. So we're going to talk a little bit about genomics. And hopefully by the end we'll at least get some sound going. This is Genomics 101, so if you've had a genetics class, this is going to be very basic, but with NIH, we certainly make sure we start from the beginning. So what is DNA? Obviously, it's the material that makes up you, right? Carries your recipes for making the next you, the genes that are used. Your DNA is more than 99% the same. That's what they're saying. So that 1% is causing an awful lot of variance in an awful lot of people. So we need to take a look at this. Our bodies are, very, very complex. This kind of goes without saying. And we really work together to make sure that we are doing the best for our bodies, both genetically and environmentally. But this is how our genes affect our health. You may have heard that breast cancer gene, there's a baldness gene, there's a cilantro gene. My one son has it, even though I told him he was crazy when he was younger. There's a lot of different genes we have. Some of them are very harmless. They don't affect us at all. It's just kind of nice to know, or funny to know, that you don't like cilantro, it tastes like dirt, right? But what if there's a variant there could make a difference in your life? A genome is a complete set of your DNA, not just the one area, but the entire personal blueprint of a person. So it's important to know the difference between just your, a DNA or your genotyping and your genomics. I will tell you right now, because of this study, NIH has actually done complete genome sequencing on 100,000 genomes. That's fabulous. That's a lot of data. There can be a lot learned from that data. So, genomics is the study of the whole person's DNA. This includes their genes and how they interact with each other. There's some more here. We talk about genomics versus genetics. Genetics is one person, like one football player, right? They're just looking at your genetics. And your genomics is how you actually work within the whole team, how it works within your whole body. So very basic, like I said, if you've had any genetics class, this is beyond 101. So what's a genetic variant, right? Most of them, we've talked about this, are very harmless. How many of you have seen the 23andMe ad where she's going, wow, I like to travel and I found out that I have, this variant that leaves me open to blood clots. She goes, you know, for her, who likes to travel, she was very interested in that. But that's just one variant. When you look at your DNA, you need to look at how it works throughout everything and through your body. Some people may have several variants, all of them benign, but some people may have variants that aren't benign, and you need to seek help. We're going to talk a little bit about some of these ethical decisions as we get this information back. How many of you have done Ancestry or 23andMe? So yeah, about 10% are raising their hands. Maybe more have actually done this. So I will let you know, your genetics have been sold. Okay, that was part of the deal when you signed it in the complete little area. If you haven't known, 23andMe was responsible for catching the serial killer in California. But your genetics in this program will never be sold to the Department of Justice. It's what NIH has promised because they have had egregious abuses in the past, and we're going to hold them to it. So when you get genetic testing, you're just really testing your healthcare providers can use to screen you for a health condition. Do any of you know here if your health insurance covers genetic testing? Some do, some don't. Anybody? We're seeing some more and more of genomics actually being covered by some insurance companies, and that's because of medications and uptake and use. And so I think that this will be used more in pharmacogenetics in the future than we are currently doing. Say, what can researchers learn from your DNA? Well, you know, obviously where you come from, what's your history, where's your ancestry, that's what most people want to know, right? You can find out about your environment, your lifestyle, your genes get impacted, identify which treatments work best for you and which type of genes. Create medications to treat or prevent common conditions. How many of you know that SSRIs can be taken up differently by different people, right? Several of you do. So I'm a provider, and I can't get my patient in to see anybody from mental health for 30 to 60 days if I'm lucky. So I'm going to start them on an SSRI. Don't you think it would be important to know if that SSRI, the patient burned it up immediately and had no effect, or if they absorbed it so slowly 20 milligrams knocked them down? Especially since we know that starting patients on SSRIs in that first 30 days can increase their risk of suicide. So as a provider, I'd like to know how you're taking that SSRI in. As a mother, I would like to know my children were being treated correctly. And as a consumer and as a taxpayer, I'd like to know we're not spending money, you know, giving people a lot of medications they're never going to take, or giving people a medication, you know, that they need 10 times of to actually be therapeutic. And we have the ability to know that about SSRIs, and I think we're going to find out much more as we move on. So what will you get when you get your DNA results? Well, if people sign up for the study, and this is, you know, for you guys to know when you talk to your patients, or you talk to your communities, or you talk to your families, they'll get their genetic results back in about 6 to 8 weeks. I will tell you, if they find kind of different variants, it may take longer for you to get your back. If you get concerned about your DNA results, and I actually love this, they actually will let you talk to a genetic counselor. So if there is a variant in your DNA, 23andMe isn't going to do that for you, neither is Ancestry. They are going to actually give you in touch with a genetic counselor to find out what you need to take to your provider to tell them. That's kind of important. Now, as a healthcare provider, you bring me your information. You come and say, hey, Colleen, look, I found out that I have a strong case of dying of colon cancer. I've got this huge family history of colon cancer. I've got a genetic variant for colon cancer. I want to get a colonoscopy much sooner than I would normally. So now I'm the provider, and I agree with them. But who do I have to contact? The insurance company, right? Because is that insurance company gonna take that information and Use it against my patient maybe in some way, or increases insurance, or deny activity? Well, they can't do that. It's illegal. But also, some patients don't want to know. And I think this is a really interesting ethical decision we make when we sign up for research studies or we get involved. I have had people say, Colleen, you can look at my electronic health record. I don't care if you take my data. I don't want to know. And I, of course, was like, you don't want to know? They go, no, I don't want to change my life. To some people, knowledge is a wonderful thing. To other people, it scares them. And they may not live a life like they would normally live. Maybe they would be the worried well. Have you seen those people that worry and ruminate about things? So you need to respect each person's choice on whether they want the data back or whether they don't, whether they want to be involved or whether they don't. So they do genotyping, small amount of DNA, and then they do your whole genome sequencing, which is huge as when we're looking at patterns, when we're looking at geographical areas, when we're looking at ethnic and cultural decisions on what that looks like. I love the fact that the last speaker was talking about when you looked at how few Asians had signed up for that study. Well, that's what's going on here too, right? We have very few Asians involved. And yet, if you look at their diet of rice and fish, that is just more, aware of the mercury. So there are cultural differences with our diets and what we do that do impact our health. So this is what they get you back, obviously, your ancestries. We talked about cilantro. I did tell my youngest for years, oh, eat it. Everybody loves cilantro. Mothers aren't always right, but don't tell him. Of course, now he's a 30-year-old Marine. He doesn't ask me too many questions. Where you have an increased risk of problems, and this is really the important part of this study, and how your body may react. They do a little pharmacogenetics, and if they see things, they'll do more, and other health-related issues. You create an account. You have to answer questions if you want to be involved. Then you have to set up a time to either get your saliva or your DNA. We talked about the egregious abuses done in the past. Out of that came IRB. I'm not sure what happened to the slide, but you get an IRB, meaning no one can just look at your data because they're interested. They have to have a research question. They have to have a good reason. Any college, any university, any healthcare system can access this database with a data use agreement. And I think this is huge, especially if you look at Kaiser here. What if Kaiser all of a sudden started seeing a bunch of 20-year-old cancer patients, their patients, and they all came from a certain area? They could utilize the database if they had enough of their own patients involved to see if there were anything either genetically or whether it was environmental that impacted the community. It's an amazing tool that can be used for good. But with all tools and with all great ideas, there's always unintended consequences. So our job is to make sure that this actually levels the playing field for all colleges, universities, not just the RO1s. And I love them. I love the big universities. They're fabulous. But there are some smaller universities and colleges that should be able to do research and have access to a research database as well. And this allows that to happen. So all of us will provide educational materials if you have DNA variants, but they really encourage you to take this to your provider so you can set up a plan, right? If you choose to. I have to tell you, CRISPR, and this was actually on KPBS, and it really made me open my eyes. A young African-American gentleman had sickle cell from the time he was very young, and severe sickle cell. I mean, very bad. And they offered him the chance for CRISPR to remove the sickle cell, meaning it would not be passed down to his family. Now, we all think, oh, sure, who wouldn't want that, right? The young man said, and I thought this was really, really enlightening. He said, no. He goes, I think my treatment for sickle cell has made me a better person, has made me face things that maybe I wouldn't have, has made me a stronger person, a better person. And he said, I will let my children decide if they want sickle cell removed. Again, we can't presume we know what everybody wants. That's that part of making sure that we're inclusive of all patients' rights and responsibilities. And just because we feel, the provider or the community, that X should be done, it's an individual decision. So this is a big question. Okay, I gave my DNA to 23andMe, or I gave my DNA to Ancestry. Can they use that? No, absolutely not. What they do to make sure the consistency of the program, right, is that they treat every biosample, I'm trying not to beat this, every biosample exactly the same, right? Because you want to decrease variation in how you handle this. And you need it for research. It was funny because I was talking to Dr. Patera. She goes, wouldn't it be great if they could merge those two data sets? I said, yes, never will happen because of IRBs, right? Yeah, I don't know how it could. Maybe it could. I shouldn't say never. But when you work with behemoths like NIH and other things, it's very hard to get them to change their protocols. And they do that for the safety of the patients, for the integrity of the program. So this is what we've done so far. We've set up locations for your biosample. They actually mail them to you. So if you wanted to sign up, you could do a saliva sample. They collect them. They say they can get better results with blood. I know there's some people who gave salivas. They found variants and asked them to come in and give blood. You can send your biosample. The biosamples go to the University of Washington and to Baylor. And then they double check them. State-of-the-art lab, you know, again, the guy that was doing the heavy metals research, they have biosamples here. It would be interesting to see if they could target those areas. They do have genetic counselors to talk to people if there are variants, which is excellent. So look where we currently are. Look at California. Good work, California. California is targeted. Why? He mentioned it in the last presentation, because we are so diverse. This is an extremely diverse state, not just ethnically, culturally, but by region, by coast, by environmental exposure. The wildfires, right? Paradise burned to the ground north of San Francisco. The wind shifted. All that particulate ended up in downtown San Francisco. It will be very interesting to see what kind of asthma, what kind of cancer comes out of that. Were there variances? Is it all environmental? I mean, it's very interesting. So what happens if you sign up and then you don't give them the right address or phone number? Well, you won't get the information back, right? So you have to make sure that you continue to update where you are. I will tell you, I don't know how many of you know this, but we were actually collecting data in New York City prior to the COVID pandemic. All of us was collecting. And obviously when COVID hit, all NIH resources, God, I'm gonna kill that thing. All NIH resources were switched over to checking for COVID, right? So all of us shut down, many different studies were shut down, really focusing on that mRNA. And what they did is use this study to go back and check the electronic health records and looked for things like shortness of breath, looked for pneumonia, looked for different things, then went back and checked the biosamples, and guess what they found? COVID in New York City way before January, okay? Especially in communities of color. By the time March got there, they were so far along, the death rate was so high. They assumed that it came from Europe, but it was in New York way before we knew. So this database, this is being used currently right now as we speak. They also are going to do something called the Million Veterans, right? So have any of you served out there? Are there any veterans? Well, many of you, when you sign up, you know, and I signed up after 9/11, I was very patriotic, signed up after 9/11. Well, they took my biosample when I signed up. They take every military biosample. And it's in a log, it's in a vault somewhere, and I want the VA to take the biosample that I had when I signed up and compare it to this one after cancer. And let's see if there's anything different. We have two different to look at. Well, let's look at them. Now, I don't know if you know this, the VA is going through a chart change, going to Cerner. It could be not in my lifetime by the time that gets done, but we really hope that we can use some of that data that our military has certainly done. There is a burn pit registry, so there are things out there. Okay, so what makes all of us different is that we really are not looking at a disease specific. It is free and open to everyone, whether you're sick or whether you're healthy. It's open to ages 18 and over. We did follow a lot of pregnant women, but because of COVID, they did not start enrolling pediatrics, which I think is a really loss to a lot of information. You'll get your DNA information back, you'll get your variant back. If you have an issue like I did with follicular lymphoma, when they reach out to me and say, Colleen, there's a study for follicular lymphoma, I raise my hand and say, please use my data, please. And I think, you know, I think that there's a lot of people who have family history of breast cancer, of Alzheimer's, of different things that are involved in this study. Whether it's going to help me, I have no idea. I mean, we all hope. But I really hope it helps my kids and my grandkids. So one of the biggest issues about this is obviously security, right? We can't protect your security any more than they're doing. It's military grade, it's double encrypted, but in saying that, if they can get into people's bank accounts and other things, there's always a chance that you may get hacked. They're open to transparency and they're supposed to let you know immediately if there's a breach, but if there's a risk, that's probably your biggest. Is it likely that my DNA will show? Well, this is kind of amazing, right? Right now, they're saying 2 to 3 out of 100 people. I think that's high. But it is a biased selection, right? People more like me are actually signing up for this. So there would be more of that. Will my DNA affect my children? Well, yes. We already talked about that. The genes are passed from father to children. Will it increase my health care costs? The answer to that is no. It will not, and it cannot be used for that. This is some information. You actually have the GINA law there that tells you it can't be used against you through your insurance company. And some insurance companies may want to do more preventive medicine with you if they actually know this. This is another wonderful video that I can't show you. We are trying? Try.
We are one nation, one people. When called upon to give from within, we come together and find that our capacity to help others is limitless. Here, we are fearless. What lies inside all of us is more than data. It's life. It's more than insight and medical research. It's vision and honor and compassion. What's flowing through America's veins is its diversity. The next great breakthrough will be found in each and every one of us. And what we find there will unlock mysteries, heal the sick, and eradicate disease. We ask for 1 million individuals to come forward and stand on this landmark in history. We ask America to do, once again, what she has always done. Lead the way forward. We're one nation, one people, but all of us are different, and it's those very differences that will lead to answers for generations to come.
So these are some different ways that you can be involved. I also have a booth upstairs that I'll be happy to talk to anybody about. This is where you can learn more. You can take a screenshot of that if you'd like. And we have the post survey. So during the post survey of time, can you do the post survey? And if people have questions, I'll take them now. That way we stay within our timeline. Or if you have something personal, I will be up at the booth. You can talk to me up there. Try to do the post survey, guys. That's how they know that you were here. Besides your picture, of which I need to get out. Well, it's not a great picture, but we'll fix it. Any questions? I can't see. Okay.
Hold on 1 second.
Military, is that true?
Probably, because once you sign your little heart away, I volunteer to protect and defend you don't, military treatment facilities don't fall under the same laws either that regular treatment facilities do. So that is, I don't know for a fact, but I can imagine that would be indeed true.
Raise your hand and we'll bring a microphone to you. Anybody else who has questions?
Maybe we can go back and show one of the other videos if we have that time. Well, we're kind of over time, aren't we? I am not a great photographer.
But lately, he's gotten
Okay, we're cueing Ray, guys. You get to meet Ray.
This is Kim. Kim lives in the city. She loves to exercise, cook healthy meals, and can't remember the last time she called in sick. They're both people, but not all people are the same. And yet, when we visit the doctor, our treatments don't look that different. Why is that? Because we just don't have enough information to do it better, until now. Enter all of us. The research program based on precision medicine. Precision medicine is a revolutionary new approach to treating and preventing disease that's personalized, instead of one size fits all. By gathering health data from 1 million people like Ray and Kim and Trevor and Samir, our country's best researchers will be able to develop treatments that are as unique and complex as we are. With this new information, doctors will have a better understanding of disease so they can innovate the next great breakthroughs in medicine. Once enough people join, suddenly everything changes. Information becomes clear, patterns emerge, and simple data transforms into life-saving knowledge. This means that Ray and Kim's children and their children's children can live longer, healthier lives. By becoming one of the first 1 million people to volunteer, you can help reshape the entire future of healthcare for generations to come. If we can figure out how to fly, put a man on the moon, and connect the entire world, surely we should be able to improve the future of healthcare. Not just for Ray and Kim or even you, but for all of us. Sign up at joinallofus.org. The future of health begins with you.
So yeah, that's Ray. Now you can see it kind of makes a little more sense, right, as you see some of these videos. And the next video is actually researchers from across the country telling different people why they should be involved.
Those that have some trepidations about it. My thing is to bring them aboard and let them know that this is for the greater good for them. We have input, and without input, there's no buy-in. And without buy-in, there's no commitment. Without commitment, there's no success.
Tuskegee happened. We're not trying to hide that or sweep it under the rug, but communities of color will be at a disadvantage if we do not find ways to get by that. Whether the focus is asthma, whether the focus is infant mortality, whether the focus is diabetes, cancer or heart disease, communities of color are disproportionately impacted by them.
It has always been playing catch-up to make sure that they're even getting access, much less minimum service. Low income, underserved, and people of color are oftentimes very generous in giving something if they understand it. And they always do so with the intention that knowing this is not just about me, this is not just even about my family, it is about helping the community down the road.
Being able to bring the Asian American population who is never at the table, not only to contribute to science, but to contribute to our ability to understand the nuances within those populations. I think it will provide a huge national data set so we can ask questions and make discoveries about healthcare that will better their own personal health and those of the communities that they are part of.
Diversity strengthens the science. It could bridge some civil rights issues and inequities in healthcare across all races and ethnicities and culture.
As a community of color, underrepresented, hidden, underserved, what would happen if you were not at the table? It is an issue of equity and it's an issue of justice as well.
It is important for minorities to be a part of this, or we will again be left with medications that are created for really other populations. I'm hopeful that we will be overwhelmed with folk.
That concludes. Thank you, guys.
Anybody hungry? All righty then. Must be students. And we're right there with you. Very quickly, my name's Brent Wood, and I'm blessed to be one of the committee members that plans a research symposium. And I'm in my 8th year in the School of Nursing, and I have had 2 wonderful mentors during that time. On the teaching and academic side, Dr. Elaine Gaynor, and I trust that Dr. Gaynor's with us online to hear that. The other mentor that has had a great impact, especially as it relates to facilitating and providing leadership for the Research Symposium, is Marilyn Klakovich. Now, Marilyn has no idea that I'm saying anything about her, because if I had talked with her, I wouldn't have been able to do it. But for many years, Marilyn has chaired the Research Symposium Committee, and we co-chaired for a while, which meant Marilyn was doing most of the work. And but it's just been such a blessing, Marilyn, to work with you. Marilyn is such an intelligent, compassionate, and organized person. It's remarkable to me how quickly she can turn things around when we need to get something done and need her feedback. So Marilyn, I know you're not going to be happy about this, but I'm going to ask you if you would just come up so I could give you these roses. And then Dr. Brash will give us the prayer of blessing for our meal. So, Lydia, I think you have something to present, and then we'll have Dr. Brash do the blessing for the meal. And then you'll be able to go have a wonderful boxed lunch.
Hi, so I'm not going to stand between you and lunch because I know you're hungry, but this is just a really quick presentation. My name is Dr. Lydia Garcia Usry, and I'm a nursing instructor at the High Desert campus, and I'm also the president of Iota Sigma. And what we want to do is to present to Dr. Feli de la Cruz a scholarship award. So each year, Iota Sigma sponsors scholarship awards to both students and faculty. We really want to reach out to the students, and one of my goals is to make that happen, to really connect with the students so that you can see the value and importance of research, because trust me, I never thought I would do research. But especially those in my community health classes, you've been doing a lot of research out in the community. But anyway, so Dr. de la Cruz, we're going to be giving you a $700 research award for your topic of scoping literature review for dancing for high blood pressure control. So Dr. De La Cruz could you please stand? Okay. All right. Thank you very much.
Dr. Marissa Brash, chair of our Masters in Public Health program, will now give our prayer of blessing, and following that, you may go in a thoughtful and methodical manner to pick up your lunch rather than stampeding. And I've let the technical folks know that they can go to the head of the line, so they'll be all ready to set up for us to resume at 1300. All right?
Yes. Do you want to go first?
Yeah, I'll do 2 quick announcements. Sorry, more people, more distance between you and your lunch. So the lunches on the side of the building, the Felix Event Center, the lunches are on tables. There's 4 different options. In between the tables that have the options are waters and drinks, so you can get that. What we would like to do after prayer, what I would like to do is dismiss the back half of the audience first, let them go and have a few-minute head start, and then do the front half of the audience, if that's okay. Second announcement I'd like to make for those that are watching online as well as those who are in here, for participation of the event, remember that is going to take place through the evaluation that is going to be given after the event. So for those that have registered, whether you're watching online, whether you're here in person, you will get an email with the Canvas course link, which will have the evaluation. That may take a few days to get to you, so just know that once it is launched, we will communicate with you around the evaluation, and that will be your way of showing participation for whether you are here in person or online. Thank you.
All right, I know you're anxious to get to lunch, so I will make this quick. Let's bow our heads in prayer. Dear Heavenly Father, thank you for keeping us safe as we gather here today for today's research symposium. Let your wisdom and love guide us as we tackle the difficult yet critical issue of health equity. Help us to learn from each other and to apply our knowledge to the effort of eliminating disparities in health and its determinants. Aid us in understanding communities that are not our own, that we may ensure better health outcomes and redouble our efforts to serve everyone with unconditional love. Please bless this meal that we are about to consume. Thank you for providing for our hearts, minds, and stomachs today and every day. In Jesus' name we pray. Amen.
The next 2 presentations will do a deeper dive in how a couple of our faculty felt that same burden and jumped into action. Amanda Thurman is a family nurse practitioner. She's currently full-time in our Azusa Pacific University faculty over in San Diego. She's doing her doctorate of nursing practice in looking at how do we better train healthcare professionals to screen for food insecurity or not having sufficient food to meet the demands of an active and healthy lifestyle. She brings to our awareness that 1 of 5 households in California are disproportionately affected by low income, especially our Hispanic and our Black families. And that includes many children. Food insecurities cause poor health outcomes, including obesity, affecting heart disease, blood sugar, depression, difficulty concentrating for children in school, as well as low birth rate. Integration of a screening for food insecurity and appropriate food source is what she's going to be talking about, the importance of active and very directive referrals, as well as making sure that we're looking out for the total well-being of our patients and their families who suffer from food insecurity in their communities. So that's Amanda. Lydia Garcia, Dr. Garcia Ursary, is one of our faculty members who's over in Inland Empire, or actually she's in High Desert, forgive me. And she has her doctorate in looking at food distribution sites in rural neighborhoods, particularly in the San Bernardino County. The purpose of what she wants to share with us is to show how social determinants of health truly affect the health of communities. So she's going to unpack that for us. She's going to look at how health issues such as hypertension, heart disease, diabetes are all correlated with lack of accessibility to healthy food resources. So both of these women are going to empower us during this time to be thinking outside of our box of how we can help the people that are near us. So first one is going to be Amanda Thurman.
Thank you so much. I'm very excited to be here today and share with you my work so far in food insecurity screening. I have lots of facts to share with you, and my hope is that through this presentation today, either as a student, you will integrate screening and asking questions about food insecurity in your practice, and if you're a student, hopefully you've had some of this content in nursing school. Quick show of hands. When you've been to the doctor's office, have you ever been asked if you have enough food to eat? One? Wow, okay, thank you. I am here to change that. Lydia and I are here to change that. So in addition to me being a full-time faculty at Azusa Pacific and a doctoral student, I'm also a family nurse practitioner at a free and charitable clinic in San Diego, which I'll talk a little bit about later. And I'm also a Randall Lewis Health Policy Fellow. The Health Policy Fellowship was created very much like with the same idea as this research symposium, culture of health equity. And so Mr. Lewis, who is a philanthropist in the Inland Empire, wanted to better his community. And so the fellowship was created to create a culture of health equity. And so my project in food insecurity tied in nicely with that. And Dr. Dodd Putera had me apply, and I was accepted to be a fellow. So I want to start with how I became interested in food insecurity. It was an interesting path for me. My husband was a principal of a high school in San Diego that was for at-risk youth, low-income kids, and he would often take them to college fairs with other teachers or other events, and they'd go out for ice cream or frozen yogurt afterwards. And he found time and time again that a few of them would not eat their ice cream or frozen yogurt. So after a while he said, well, why aren't you eating that? Come on, you deserve it. It's good. And they said, no, I'm saving it for my little brother or my little sister. And after a while I thought, gosh, that is not normal teenage behavior. And I started researching that a little bit and realizing that it was a coping mechanism for food insecurity. When I looked more at food insecurity, it's a risk factor for suicide in adolescents. And that really struck me, and I thought, wow, there's a lot to food and our emotions. Think about your own family, your traditions, the tie of food with emotion, and you can imagine not having enough food chronically and how that might affect emotional and physical health. So we'll get into that. I like this quote. I found it at the Getty Museum. It was about art, and it's by Thoreau, and it says, it's not what you look at that matters, it's what you see. You are looking at people that are food insecure. You just probably don't see them yet. And so that's been my goal, is part of my presentation today, is how to identify individuals that are food insecure, the health effects of it, and then what you can do about it. So, as I said, you're looking at it, you just don't see it, because an astounding 1 in 3 people in the world do not have enough access to food, and 1 in 5 Californians are technically food insecure. As we heard the definition a minute ago, food insecurity is defined as having consistent access to food to live an active and healthy lifestyle. So think about what you need to live an active and healthy lifestyle. You need lots of protein, fruits, and vegetables, and not just carbohydrates to really live an active and healthy lifestyle. So that's the definition of food insecurity. COVID, of course, we saw lots of health disparities, and food insecurity was not spared. Spring of COVID caused a doubling in food insecurity, and if there were small children in the home, food insecurity tripled in the home. Immigrants, of course, are disproportionately affected. If the income is low, the immigrants that are most affected are those without status, the undocumented immigrants, because they are not extended federal or state food benefits that I'll talk about later. College students, 30% of college students are food insecure, even at affluent universities. And so we really need to think about that. That increased to 38% during COVID. And our social determinants of health, we really need to take a look at them. Food insecurity is one of them. Housing insecurity is another one. Transportation, literacy, they affect 50 to 60% of our health status. So if we're not addressing these fundamental issues, how can we truly address the health of our patients in the hospital and clinical setting? So the problem is we don't have enough food. There's plenty of food in the world. It's not distributed properly. There's a lot of food waste, individual food waste, corporate food waste. 108 billion pounds of food is wasted each year in the United States. It's 130 billion meals and $408 billion worth of food is wasted. So as you can see, the problem isn't enough food, it's getting it into the homes of those that need it, and identifying those that are food insecure and connecting them to resources. So what really interested me also is what happens when food is scarce in the home. What behaviors do people do? Trade-offs occur. You can imagine if you have a fixed amount of money by the end of the month and rent is due or you're going to eat, you have to probably pay your rent versus eating, and you'll sacrifice healthier foods for unhealthier ones. If your insulin needs to be refilled and you need to buy food, which one do you do? Many people pick the food over the insulin. So you can see already how this leads to health problems. Health declines in general. I'll go into that a little bit more in the next slides. And our mental health worsens. A lot of anxiety and depression over not having enough food chronically. So what we see in the clinic setting, in the hospital setting, is food insecure adults tend to be obese. A lot of people think, well, gosh, aren't you skinny if you can't get enough food to eat? No, because we have in the United States a lot of cheap, unhealthy food. And think about it for a minute. If you have $5 to feed your family over the next 2 days, you know, it's a natural inclination to eat high-fat, satisfying, delicious foods off the dollar menu than to eat fruits and vegetables that won't fill up your family in the same way. Depression, anxiety, not knowing where the next meal will come from, and also poor control of diabetes and hypertension, because those trade-offs do occur at some points where food is purchased over medication. Some people even pawn items to purchase food. Now, women bear the brunt of food insecurity. This may or may not surprise some of you. Women will feed their husbands and kids before they feed themselves. So for those of us that I'm a family nurse practitioner in a clinic, a lot of my patients are women, and just even acknowledging and asking the questions about food insecurity and acknowledging their role and their sacrifice in food insecurity is something that makes them known and heard. Pregnant women begin their pregnancy, usually if they're food insecure, with a higher weight, which can lead to pregnancy complications and poor birth outcomes. Postpartum women, this one fascinated me quite a bit. A food insecure woman who just gave birth feels that her breast milk is not sufficient to feed her baby because she's been hungry. So that leads to lack of breastfeeding and overfeeding with formula of this child because they're projecting onto their child that they're hungry. And so the emotional consequences are just overwhelming. And if you work in pediatrics, the parents are reluctant to disclose food insecurity for fear that CPS, Child Protective Services, will be called on them. They can't feed their child. Are they a fit parent? So there's a lot of barriers, as you can see, and a lot of fear and shame around this topic. The children, we have higher incidence of asthma, anxiety, depression, dental cavities, and also it can mimic ADD. So again, if we're not getting to the baseline of our health status on someone, a child could potentially be treated for ADD with medication, but really what they are is food insecure and need to talk about it and have some therapy. So what can we do as nurses, nurse practitioners, advanced clinicians, researchers, clinical nurse specialists? What can we do? Well, I've come up with 3 things. We can ask about it, we can offer access, and we can create awareness about food insecurity. There's this really cool thing called the Hunger Vital Sign. It's super easy to implement in your practice. It's 2 questions, and it's become known as a very sensitive and specific tool for identification of food insecurity. So, it's 2 questions, and the first one is, within the last 12 months, have you ever worried that the food would run out before getting money to buy more? Second question, so you don't even have to run out. You can be worried that you're going to run out. The second question is, within the last 12 months, the food we bought didn't last and we didn't have money to get more, so maybe you did run out. If you answer sometimes true or always true to one or more, you're diagnosed technically as food insecure. It's very, very simple to ask those questions and very fast. It doesn't take much time in the clinic or the hospital setting. You can also, it's a billable diagnosis, and I think a lot of people don't know that. So Z59.4 is the diagnosis, and I'm not a reimbursement expert, but I assume that you could get some reimbursement for that. So I just want to tell you briefly, my Doctor of Nursing Practice project is on provider training for implementing food security in the healthcare setting. So I've just started my data collection. It's been very exciting for me. I'm implementing this Hunger Vital Sign into our routine practice. I'm training nurse practitioners to do it. I work at a free and charitable clinic, which is free care for those that have no other services, and that is the undocumented population. I've worked there for 15 years, and I just love my patients so much. What we found so far, I only have a sample size of about 30, is we have 55% that are screening positive for food insecurity. I suspect it's higher because it is a shameful response to give at times, and I think there's a lot of embarrassment. And many of my patients are afraid to apply for CalFresh, which is the state resource food money for food. So they're afraid to apply because fear of getting their immigration status known. So far, though, with our provider training, we've had 81% compliance in asking the questions. I've had some very interesting results, and I'm not doing qualitative study, but that will probably be my next step, because I'm really interested in how the patients cope when they don't have enough food. And just a quick story, one of the patients said, yes, we're food insecure, but my husband won't let me go to the food banks because of shame. And so she said, I go and I put the food in a Vaughn's bag. And so I come home with groceries. And so again, people find ways to feed their families when they need to. So a lot of resilience in the population too. Okay, so there are some barriers to screening. A lot of providers don't know what to do with a positive result. So there's a lot of referral education that need to happen. There's education that needs to happen on how to screen. And I would argue that we need to screen because we'll miss these causative factors, these underlying factors of why the diabetes isn't controlled, why the hypertension isn't controlled, why a child looks like they have ADD, when really it's food insecurity is the issue. And we need to incorporate it in nursing education and medical school education as well. So in terms of the second A, access, Feeding America is fantastic. They have pulled a lot of people out of being food insecure. There are local food banks. You can look at the website, and there's usually a local food pantry in someone's area. Do they have access to it with a car? That's another social determinant of health that you have to access as well. But a lot of churches partner with Feeding America and have that as a resource. You can also connect your patients to SNAP. That's the federal program. It's called CalFresh in California. And they offer monies to help people that are 130% or higher of poverty level. And like I said, an undocumented person is not eligible unless they have a US-born child that is 18 years or younger in the home. So you can also become aware of the food waste in your own home. And I'm going to talk about a challenge here in just a minute. Be aware of your neighbor, and of your patients, and also now be a good steward of your food. Grocery stores just this year have been mandated to donate extra food to food banks. Before, they would throw it away. Good food that would get thrown away. So now there's a mandate to send it to food banks, so that's good. Consider trial the SNAP challenge. So I'm going to tell you about this. SNAP is the federal food assistance, CalFresh is the state food assistance. And so under the, Dr. Teresa Dodd-Butera has been my mentor, and under her mentorship, I had the idea to do this thing called a SNAP challenge. You can look it up, there's documentaries on it, politicians have done it, and what it is a trial of living for a week off the allotment that somebody gets for food assistance. So several of us did it. Dr. Dodd-Butera did it, myself, my husband, and a few people from the Randall Lewis Health Policy Fellowship. And for 1 week, we spent the allotted amount for food and lived off of that and kept a log of how we felt, what trade-offs we had to make, etc. Granted, I may never know what it's like to be fully food insecure, but that week was life-changing. So the allotment that you get is $52.18 for 21 meals. So here's what I bought. I went to the Walmart neighborhood market because I found that that had the best food prices, and I spent $49.45. I wanted a little extra in case I wanted a little snack during the week. But it was really interesting because I had to weigh all my fruits and vegetables, which I never have needed to do. I had to put some things back because I didn't have enough money. I tended to buy a little more carbohydrates that I normally eat, and I couldn't afford a lot of protein. So I just was interesting shopping with that amount of food. There's such a connection between food and emotion. So I actually reached for milk for the week, and I was really afraid of being hungry that week, I'm gonna say. I reached for the milk, and I was gonna buy my normal 1 or 2%, but I actually bought the whole fat milk because I thought, I can't be hungry this week. I'm busy, I have things to do. And so just right there, that trade-off of an unhealthier food choice, but that's what my instinct, kind of went towards, was self-protective. So that was my food for the week, and we logged and we journaled, and it was really interesting because I really had to make sure my food was prepped and that I had enough food. I couldn't go out. I didn't want to go out, so I socially isolated because, as you all know, we go out to dinner and spend the $50 in one sitting, and so that was our money for the whole week. I wasn't very hungry because I really protected myself against that. I did have some anxiety because I had to prep all my food. I definitely ate less fresh fruits and vegetables, and the biggest takeaway for me was an incredibly great appreciation for my food and realize how much I waste. I am a huge food waster. I clean out my fridge and throw away so much stuff, so that convicted me of that. So if anybody wants to do the SNAP challenge, I will walk you through it. I will do it with you. It was a really, really, really great week. Tough, but really good. So in conclusion, please, we need to start asking our patients those 2 simple questions, referring to resources as needed. We have to be aware of these social determinants of health because knowing what is driving your patient's health is so important, and it'll help you treat them the best in the hospital setting, the clinic setting, wherever you may be working. So we can ask with the 2-question hunger vital sign, we can give access to food resources for our patients, and we can be aware of resources in the community and the emotions that our patients experience when they're food insecure. So here is my contact information. Again, please reach out to me with any questions, and thank you for your time.
Hi, let's see, are my slides up? Okay, hi, my name is Dr. Lydia Garcia Usry, and I'm a nursing instructor for the High Desert Regional Campus, and I'm a lifelong resident of Victorville, California. I'm a first-generation college graduate, and I actually grew up in the barrio, and I loved and felt the greatest feeling of love and family there. My grandparents were immigrants from Mexico, and my parents never graduated high school. My dad was able to get his high school diploma through a veterans program since he was a World War II vet. He was so proud of that high school diploma. I received my doctorate in nursing practice from Azusa Pacific University in December of 2019, and today I'm presenting my DNP dissertation, Impact of Food Distribution Sites in rural neighborhoods at risk for food insecurity in San Bernardino County. And like Professor Thurman was saying, I attempted to do the SNAP challenge, and I was too scared to do it. So let's see, oh, there we are. Okay. So rather than go through all the research and material, I'm going to tell you the story of how my research project and how nursing is vital to address food insecurity. I encourage you to read my research online or just simply ask me about it, and I'll be more than happy to talk to you. But let me start on how and why this research topic came about. And it's really what I've said earlier, is that because I'm a lifelong resident of Victorville, there were social determinants of health that had a high indication of poverty. And so I wanted to take a look at it. So, I think I have to, sorry. Okay. So, okay, on this slide, you will see pictures of the food bank, and I have my nursing students that were actually doing their clinical rotation at the food bank. And as Professor Thurman has already previously stated, healthy dietary intake is critical in the prevention and management of numerous chronic diseases such as obesity, diabetes, coronary artery disease, and congestive heart failure. And food banks have the potential to improve food insecurity outcomes when operational resources are adequate, provisions of perishable food groups are available, and client needs are identified and addressed. So here are my objectives, and it's what we've been talking about, is to address the significance of food banks in a rural community. So to ID the significance of the problem, I did some research, and I found that the high desert cities, such as Adelanto, Apple Valley, Hesperia, and Victorville, collectively had an overall poverty rate of 25.6%. So this is in comparison to the national average, which is 11.4. The state of California is 11.5. San Bernardino County is 13.3, and households that report to be food insecure are 13.4%. So that is a huge amount. So since my time working in the community, as I said earlier, I would notice a certain trend in healthcare accessibility and increase of unhoused individuals. And I would attend community meetings, and one of the concerns that came about was regarding food access. Okay. So the significance of the problem is that St. Mary's Medical Center conducted a community health needs assessment report and focused on the areas of Adelanto, Apple Valley, Hesperia, and Victorville. And participants expressed the concern of cost and preparation of healthy food, quality and availability of supermarkets, and participants believed that living in poverty was a root cause of their health issue. So there was a call out to action within the high desert community of March of 2016, and 80+ agencies met on that day. And the purpose of that meeting was to find out if these individual agencies were interested in forming a collaborative to provide a central site to pick up food for distribution. This meeting was inspired by Kaiser Fontana and St. Mary's Medical Center. I was invited by St. Mary's Medical Center by then Director of Community Services, Kevin Mahaney, as he was familiar with APU nursing students who were part of the data collection for the community needs assessment. He thought this meeting would be good for APU and for the members of this meeting. But me being an outsider, I was not readily welcomed to this first meeting, and Kevin had to explain how I and APU were partners and with St. Mary's, and how helpful my nursing students were, and how we were able to be part of this collaboration. My interest in being part of this food distribution site was to bring a healthier community, and I was envisioning student nurse involvement, but not sure how this would all come about, but I was interested to find out. I was the first and only nurse to be allowed into this organization. The consensus of the meeting was that there was a desire to have a central hub for food distribution so food would be readily distributed and fairly and equitably. During this meeting, a food distribution model was presented. Agencies agreed to select a central hub that would host the first food distribution site as a trial run, and this was at High Desert Second Chance. Their first hub distribution was in October of 2016, and once a precedent was established, 7 agencies signed up to receive supplies for the first food distribution. By the second month, 23 agencies signed on, and by the end of the first year, 32 agencies became partners. Year to date, as of 2022, there are 93 agencies, and we've expanded to a food distribution hub in Adelanto and one being formed in Barstow. Okay. So the purpose of my DMP project was to assess if rural communities such as the high desert of San Bernardino County were at risk for food insecurity, and if food distribution sites would provide an impact to provide access to healthy food. And I used Nora Pender's health promotion model to explore how environmental factors influence health and behaviors. On this slide, you will see the High Desert Food Collaborative, and you will see there we have a banner. The story behind the development of this banner is that Kaiser Permanente offered $1,000 for the development of a recognizable logo, and High Desert Food Collaborative reached out to our partner, Victor Valley Community College's Art and Media Department. And you'll also see 2 food trucks here that belong to the collaborative. Previously, individuals working for the various agencies would drive their individual cars to collect food and use their own time and money to transport food. The money they would have spent on gas and wear and tear on their vehicles now is being used for the people they feed. Through the efforts of the Food Collaborative Board, we were able to purchase 2 food trucks. The first truck that says High Desert Second Chance Food Bank was purchased with grants from IEHP, St. Mary's Medical Center before coming Providence, and Inland Empire Community Foundation. December of 2021, we were able to purchase a 26-foot box refrigerated truck. The second truck was purchased with grants from IEHP and the Raymond Pike Foundation. Refrigerated trucks help to ensure consistent temperature control needed for safe food transportation. And the collaborative's primary food sources come from Community Action Partnership through San Bernardino, the Rock Church, and Food Forward, and other food is purchased through Feeding America. And here is a slide showing the great health need in the high desert. So the red being very high and the pink being high. So we have a very high level of health need in the high desert. So we do a literature review. And so the literature review that I was able to do indicated that articles regarding health outcomes and healthy eating were not readily found. Literature available was primarily from social work publications, nutritionists, and government agencies such as Human Health Services, USDA, and the National Cancer Institute. Nursing publications regarding food security or insecurity were not readily found. There was an article written by the Woodhill Study Revisited that found that nurses were never cited in health nurse stories on policy and were very rarely identified in photos that accompanied articles. This indicates a gap as nurses provide a critically important role in ensuring patient safety and ensure patients receive high quality care. So I go to my methods, and primarily my research design is a quantitative descriptive design. My sample size were 49 individuals, 20 men, 29 females, 18 years and older. The survey was done primarily by English and Spanish speakers, and I received IRB approval from Azusa Pacific University. The recruitment sites were selected on the geographic location that were frequently utilized, being the Lord's Table, which is in Old Town Victorville, Another Level for Women, High Desert Transitional Living Church was also included, and each site was advised of the purpose of the survey, and permission was asked from each of the director, and each of these surveys were going to be anonymous, and no one would be turned away if they did not participate in the survey. I also received letters of support signed by each of the site director to conduct the survey. And here is a slide of my research assistants. The first gentleman there, Gabriel Kevlin, he went on to UC Berkeley to start his political studies at UC Berkeley, and now he's on his way to Harvard Kennedy School for his master's on public policy. He credited him being able to get enrolled into Berkeley as being part of the research study. Tina Kennedy is now president of High Desert Second Chance, and Ligia Sanchez was my Spanish speaker who helped with the translation. And here's a picture of my table which showed the fruits and vegetables, where we were able to show the individuals the actual serving sizes and portions that were required to eat. And then my data collection tools, demographics, it went from zip code, gender, date of birth, age, and also I wanted to know how many miles to the nearest grocery store. The Household Food Security Survey was developed by the USDA, and it's free and available on the USD website, and it helps to measure the level of food insecurity in a community. And then also to the 2-item fruit and vegetable cup survey. This was developed by the National Cancer Institute. So the data was analyzed, and the results of the data indicated for the demographics that participants over age 50 received almost 50% of the food, compared to 34.2% of participants under the age of 50, and 5 miles was the mean distance to the nearest grocery store. The Household Food Security Survey results are exactly what Professor Thurman was talking about. Almost 80% worried that food would run out before they would have money to buy more food. Over 90% bought food and did not have money to get more food, and almost 90% could not afford to eat a balanced meal. The fruit and vegetable results indicated that there was an increase of fruits and vegetables after participants had access to the food banks. So the reporting of the data. So you would see here that the High Desert Food Collaborative model was noticed by No Kid Hungry. And you can see they are a center for best practices, which would indicate they're a gold standard for this type of work. So No Kid Hungry put an invitation to the Food Collaborative Board to send representatives to their No Kid Hungry National Convention in Louisville, Kentucky. And Jennifer Rich Silvestri, who spearheaded the initiative to start the collaborative, and Bill Edwards, who's the director of Victor Valley Rescue Mission, accepted the invitation as the lead agency, were the representatives to this conference. And the goal was to find out how the model of the High Desert Food Collaborative could be used in other rural areas. All right. So here we see some of the programs that we have. The programs at the Food Collaborative. Once the data was collected, we started to put in programs into place. And one of the programs that's being used right now is a senior program which Feeding America sponsors. Is a commodity supplement and food program which services individuals 60 plus and over. And it's interesting to note that the seniors, when they receive the food, would look at the food labels and see that there was too much sodium or sugar into their foods that they were receiving. So they expressed a desire to have healthier foods. So through the Food Collaborative, through the president, Tina Kennedy, she was able to collect healthier foods for seniors since they were so concerned about their what they ate, and this was helped to manage their diabetes and blood pressure, right? So as we heard earlier, you know, food does make a difference in your health outcomes. Other programs that the Food Collaborative provide are services for vets and homeless. There's an emergency food program so that at the time of discharge at St. Mary's Medical Center, they're giving information to access the food bank. And here you'll see some other health services that we do through the Food Collaborative. Up in the top left-hand side, you will see Simba Clinic. It's a nonprofit, faith-based clinic providing primary healthcare services to uninsured patients in the high desert. In 2020, in conjunction with St. Mary's Medical Center, they offered free biweekly COVID testing to the food bank workers, and those 3 students were our high desert nursing students who were asked to be part of this. Community Action Partnership and High Desert Food Collaboratives are partners, and they also designed a financial literacy class which helps create a financial plan. This class teaches how to manage money for families and to create a budget. There's also assistance for utilities, infant car seats, free COVID home testing, Medi-Cal enrollment, and food vouchers. We also do health and wellness classes at the food bank in conjunction with the Ready to Read book club, and it focuses on adult and senior healthcare topics such as hypertension, talking to your doctor, diabetes, and nutrition, just to name a few. The other thing that we started doing a few semesters back was focusing on the pregnant moms. So you can see there's some pictures of some gift bags, and on the top right-hand side, you'll see some students helping at the baby shower that we would offer to the mothers after they attended classes, and some of the gifts and prizes they would get, which would range from strollers, diapers, formula, baby clothes. You know, the mothers really got a lot of services. The topics that we picked were to coincide with March of Dimes that identified our area, the high desert area, as having a high Black infant mortality and morbidity rate. So what we were focusing on were mental health for the mothers, postpartum depression, birth control, gestational diabetes, and domestic violence. On this slide here, another thing that we do to provide an atmosphere of unity was that we offer various holiday events. Halloween, Thanksgiving, and Christmas are sponsored by the High Desert Food Collaborative. You can see a group of students. We dressed up for Halloween. There was food to be given away, games. There was candy, a lot of candy, and so we dressed up for that event. You'll see SNAP president from High Desert, Dolores. We were doing Thanksgiving giveaway for turkeys, and you can see the long line there for the turkeys. There's also was a Christmas event too that we did. Here you will see a mural on the upper right-hand side that students from cohort 30 did. The mural is a multicultural hands mural, which is a symbol of the High Desert Food Bank, and the multicultural hands are reaching toward each other from around the world. And so the students that did that are Aaron, Candace, and Miguel from cohort 30, so they did an outstanding job. Another thing that we did at the food bank is last summer with cohort 29, we did a back-to-school event. It was a summer camp theme where we'd collect food, non-perishable food items to be placed on the students' backpacks, so when they went to school, they would have a snack to eat. And this was in conjunction with the Victor Valley Rescue Mission, so we do that every July. Up at the top, you'll see a carnival game that the students crafted that would coincide with their teaching projects. And in the middle, you'll see cohort 29. St. Kaiser was there, and they liked the APU nursing students so much that they said, hey, take a picture with us, so when you do your resume, you can say you worked with us. And High Desert Second Chance is one of the only organizations known to have an access for a reference portal and provide a personal referral for nursing students when applying to Kaiser and Providence St. Joseph. So they really do an outstanding job. And here is cohort 31. They're working at the food bank, so you can see all their smiling faces. It's a lot of hard work. Even my clinical instructor, Edgar Benitez, steps in and helps out too. So it's all hands on deck. And there's also cleanup. So students, they would mop and clean to make sure that the area was looked presentable for the next time we had other events. All right. Also, with a new food go to waste, we also all food that is non-edible is given to local animal sanctuaries, the 2 local zoos. They also go to compost center. Cardboard is recycled as well. And I don't think the last slide is here that I wanted, but here's the farm animals that are enjoying all the tasty food. Okay, so in conclusion, food accessibility is provided through the food distribution, and seniors do present a large percentage of the food taken. And money needed to purchase food is an ongoing demand, and we're constantly working on that. Future research, we're looking at health education to ethnic populations, and also we're determining if healthy eating is linked to poverty. Then the next step would be to measure the level of poverty after 5 years of access to healthy food. One other research that came about is that I was studying the impact of COVID on food banks, so I already collected the data on that one. I don't think these are the last slides that I had sent, but one of the things that I wanted to say is that, so where do you start? You know, you start with your passion. You start with what you like. And you have a tremendously supportive doctoral staff here. They stretched me in many ways that I did not want to get stretched. I didn't think I could stretch that far, but they moved me. So, you know, you have a good support team here, you know, if you go in for your doctorate. The only reason I went in for my doctorate was so that I would be able to provide useful tools for the food bank. That was my passion, and that's what we do. So, you know, so I encourage everybody here, you know, whether you're just starting in the nursing program, you know, stretch yourself. This is what we're here for. We're here for you. Thank you for your time.
Dr. Lama, as was announced earlier, her presentation will be available online, and you'll have an opportunity to see that. So as a result, we've decided to go ahead and start with my presentation and to eliminate the break and let you go a little earlier. I've never known anyone who doesn't want to leave a little earlier if we give you the opportunity to do so. So I'm hoping that that's going to work out well for you. But I'm going to change a little bit in terms of my area of emphasis. As Dean of the School of Nursing, I've been at APU for a long time. In fact, I am celebrating 40 years here which actually is amazing, because when I first came to APU, I thought, I'll stay at the most 2 years and then I move on. I came from Cal State LA. I had other thoughts, other things I wanted to do. But there's something about APU that just embraces you, and that meets both the spiritual as well as the professional needs. And so I've seen APU literally grow up along with many of the individuals that are your faculty today were former students of mine, and so it's been a pleasure for me to be involved in that. But as a result of that, I want to go back and do a little bit of a revisiting, get a perspective, not only on the environment and the toxins and the pollutants and the impact that our current world has on its population, but to kind of remind us that the past is an important consideration because it influences the present and it sets the stage for the future. And the past also, the decisions we make in the past are the decisions we have to live with in the present. And so in my journey here at APU, I'd like to share with you some of the past of the School of Nursing at APU and how it has influenced us into the present that is here today, and how I hope it will guide us into the future, which is what we all need to embrace. The important pieces of that is that the past is a guide for us. The past is an opportunity to learn for us, and the past is worth preserving. I mentioned that nursing education needed to change in order to prepare nurses for future healthcare in my welcome, and that future healthcare has unique challenges, particularly as it pertains to equity in public healthcare systems and in healthcare systems. Inequities in health stem from structural inequities, and I think we've just seen an example, a really vivid example, of both food insecurities and the access to food. Inequities that stem from structural inequities are really systemic disadvantages of one social group compared to other groups, something that is often deeply embedded in our fabric. Nurses have traditionally been concerned with these issues of access, equity, and vulnerability. Preserving our past means that we focus on core values and principles, practices that are at the essence of nursing care, even as we look to changing the future. It's important that we both recognize the values that drive our profession and to understand what that means for us moving forward. All of you have heard about Florence Nightingale. You're very aware, I think, of the many lessons that she was foundational to developing modern nursing, I think, in terms of their access and interest in data and the use of data to deliver care. See if I can do this correctly. Am I hitting the right key? Okay. Technology is not my friend. Am I? What? Okay. So one of the things I wanted to mention is that the School of Nursing has long treasured its relationship with the Western Conservancy of Nursing History, and that's located on the Monrovia campus. Phyllis Esslinger, the current president and founder of the Western Conservancy, was a longtime faculty member in the School of Nursing and holds the title of Faculty Emeritus. She continues to serve the Conservancy and its board of directors as the organization's president, and she states, "I believe in the importance of understanding the historical and scholarly significance of nursing's past in order to effectively promote its future. In partnership with alumni from hospital schools of nursing who are now closed, the Western Conservancy is collecting oral histories to capture memories before they are gone via written documentation, audio, and video recordings. Their vision has become archival, and the Archival Center for Research, the building of an archival lab, and ultimately the development of a PhD program for nursing history has been some of their visions. That vision is slowly becoming a reality. The School of Nursing has recently added 2 new courses in nursing history to its graduate programs, and we are excited to be able to offer those courses to students as an opportunity to explore the history of our profession. So why do we look back at the past? I mentioned that it shapes the present and the future. But should we not actually focus on the future? I would argue that our dreams in the past not only shape the present, but our dreams of the past is the fabric of the future. The past creates important lessons for us, for the present, and there's an old saying that those who forget the past are doomed to repeat it. We want to learn in order not to repeat. The past also calls us to action in the present in order to shape the future. Mahatma Gandhi stated, "The future depends on what we do in the present." So the actions that we take today are going to be critical for the lives we lead and the care we provide tomorrow. So what are some of the things we need to think about? Well, first of all, history tells us that the nursing shortage will continue. We've gone through cycles of nursing shortage and occasionally oversupply. But as we look to the retirement of nurses in the next 10 years, when we see about 1 million nurses are scheduled to retire, we need to focus on the fact that we do need more nurses. This is great job security for you. But here at APU, for the last 50 years, we have made deliberate choices to grow the profession. We started with a very small campus. I'm forgetting to move my slides forward. I am not doing too well here. Is this out of juice or not? Point downwards, got it. Here is the picture of Phyllis Esslinger. There we go. I don't think this is me. Just go right. Okay, try this one. There we go. I guess it is me. So I'm going to move forward. This is the first nursing class. And I wanted to just emphasize for you that the future vision for nursing starts small. Our dreams shape the future. This is APU as in 1899 as a training school for Christian workers. And it is on that faith tradition that we build the School of Nursing. Oops. This is the first School of Nursing building. I actually had my office in that building. It was called the Yurt. It was a round building. And if you ever try to put rectangular desks in a round building, you'll realize there's some real challenges with that, right? And so it no longer exists, thank goodness, but it was where the School of Nursing started in 1975. This was our first graduating class in 1977, and at that time, Azusa Pacific University was called the Azusa Pacific College, and the School of Nursing was a department of nursing. We graduated 25 nursing students annually. Over the last 50 years, as we have grown, we're now at the point where we are graduating 650 BSN students annually, 3 graduations, and this is an example of filling this room with our nursing graduates. So why would we grow nursing? And I think it's really important for us to say we don't grow nursing just for the sake of growth. We grow nursing because there's a need for nurses. And there's a need for nurses with a BSN degree. When we reflect back on why the profession is so needed, we realize that healthcare, 70 to 80% of healthcare is delivered by nurses. And so nursing growth is a critical part of growing the profession and growing the services, the healthcare services for our nation and for the world. 650 BSN graduates per year is large compared to where we started, but it's not large compared to where the needs are. What we're looking at is needing an additional 200 to 300,000 nurses annually over the next several years. In addition to the growth, we also expanded our nursing schools. Now, expanding nursing schools means that not necessarily that we expanded the school itself, but we expanded programs into areas that really required and needed nurses. One of the first areas that we expanded to was San Diego and San Bernardino. And so what you see on the slide is the different locations. San Diego is, I believe, at the top, and then we have IARC, and then High Desert, and then Monrovia. The reason for expanding our School of Nursing into those areas was at the request of the healthcare providers and the schools in that area. They needed BSN nurses, they needed BSN programs, they needed nurses who reflected the community. And so our presence in that area were a strong commitment to growing nursing, to growing the profession, but also to reflecting accurately the vulnerabilities in the community in that particular area. In addition to growing the School of Nursing, we also grew pathways for nurses. Initially, we had a 4-year traditional undergraduate program. We added a small graduate program, and then in 2003, we started really focusing on creating pathway. And the vision and the mission of that was that no matter where a nurse was, no matter where a student was, there was a method and an approach and an opportunity for them to gain an education. So one of the first programs we did was the entry-level master's program. The entry-level master's program allowed individuals who had a bachelor's degree or greater in any other field, and so many of you in the room are part of that program, who wanted to become a nurse, who had perhaps had a career in another area but wanted to become a nurse, could become a nurse through an accelerated BSN and then move on to a master's program. The BSN transfer programs was started because we had students who had been waiting for 2 or 3 years trying to take courses, trying to get in nursing programs, who had been in all science courses in community colleges and could not get into the programs there. And so the BSN transfer program was an opportunity for nurses to enroll, or for students to enroll nursing programs who had at least 2 years or even slightly less of coursework. And again, High Desert is a great example of it. That program is also in Monrovia, and that program is in IARC. In addition to starting the BSN transfer program, the LVN to BSN program was a core component of that curriculum. So the LVN to BSN program was a sequence or an addition that was started when we had about 3,000. Personally, I received about 3,000 petition with about 3,000 students saying we cannot get into a nursing program, we cannot get our BSN degree. Would you consider starting an LVN to BSN? And so we did, and we moved that to different areas. Again, many of you in this room are part of that transition and have taken advantage of that. We, as part of a pathway to higher education, as part of a pathway, because besides the nursing shortage, we also have, let's see if I can. So by the way, these are the areas we cover, and that's most of Southern California. And this re-emphasizes the importance of continuing to grow our nurses. But in addition to growing our nurses, we need to grow nursing faculty. And so some of you have already experienced the difficulty that is present across the nation in the surge of retiring nursing faculty, of nurses leaving the profession, and of the difficulty of offering programs in nursing when there are not sufficient faculty to teach it. The PhD and the DNP program at Azusa Pacific University School of Nursing are part of the attempt and the mission that we feel of trying to create new faculty. And so when I hear Amanda Thurman and Lydia Garcia, Dr. Garcia, presenting their studies and teaching you, what you're hearing and what you're seeing is our opportunity to grow our nursing faculty in such a way that they both exemplify the mission of the institution as well as the importance of teaching nurses for future generation. What you're seeing right now is on the slide is graduating doctoral students and some of their faculty during the midst of the pandemic. And here we have continued to, and we have a steady stream of doctoral prepared nurses who are now entering the workforce as faculty and advanced practice nurses. So why do we need more advanced practice nurses? Why do we need more doctoral faculty? Why do we need more doctorally prepared nurses? Why do we need more research? Because the profession really challenges us and calls us to go into areas where we haven't gone before. Family nurse practitioners, now in addition to a nursing shortage and a nursing faculty shortage, there is a primary care physician shortage. Family nurse practitioners are filling that gap. Only about 1% of the healthcare providers are interested in geriatrics. We need increased specialization in geriatrics. And so nurse practitioners and healthcare providers that continue on into the doctoral level are desperately needed to take care of the increased surge of not only elderly, but increased surge of individuals who are planning the increased surge of individuals who are retiring and are leaving the workforce as well. Community and population health, we've heard a lot about today about how important community and population health is and what we can do in the future in terms of providing care for that. Mental health is a particular passion of mine. We talk about biobehavioral health and its influence on nursing and care and the disease process. We now know that over 50% of all illness is heavily influenced by the mental health status of the individual. And so expanding both in the curriculum and into the advanced practice area, additional mental health practitioners is really critical. There's a very important paradigm shift that occurs with movement to a different form of nursing education. One of the things that AACN, which is our national association and part of our accreditation process, AACN has moved the curriculum over the next 10 years, mostly the next 5 years, to a shift to measure competencies and to set up the expectation of competencies rather than content knowledge. This is also going to be reflected in your NCLEX examinations. Movement to competency changes the curriculum dramatically, and it's really important for us to realize that that change in curriculum is something that allows us to re-examine and re-evaluate as we move into our future thinking, what it is that creates a competent nurse. And often we have looked at nursing as something like a smorgasbord of skill sets, right? We focus on the skills that we have to learn rather than the process of what it means to be a nurse. And more we're realizing that clinical reasoning is the critical element, the ability to make decisions, to understand the complexities of disease process and health process, and to make appropriate decisions is much more critical than learning a particular skill. That doesn't mean you do not need skills, but there are a variety of ways in which we can obtain skills. And so one of the things we're looking at, of course, is more of a virtual experiential learning modality. Direct patient care will always be an important part of nursing education, but in the future, as we look at what we have learned from the past, we realize that alternative experiential learning methodologies are also really important in giving you the confidence and the understanding of practicing not only your skills, but seeing it in a virtual and applying it in case studies and in virtual case studies. So virtual experiential learning, simulation, and skills will continue to be part, but the formula may shift over time. And particularly as clinical placements become more and more challenging and harder to obtain with the growth in nursing education and the needs for more nurses, you may see more of a partnerships with our clinical facilities for graduate education following a modality that leads to BSN straight into a doctoral program. And so one of the things that we have looked at is for those of you as you graduate, instead of going into a master's degree and then moving into doctoral education, that the BSN to DNP and the BSN to PhD will be an opportunity that will be offered to you in the near future. In addition to that, we're partnering with as an academic unit with clinical facilities on new grad programs about using some of your learning experiences in your internships and your residency programs as a leverage into new grad programs. Again, trying to maximize on clinical experiences and build on additional resources through virtual and skills and simulation. Telehealth is, we now have a program that where we're starting to teach telehealth, and telehealth will be an integral part of nursing education moving forward. In addition, artificial intelligence and the use of artificial intelligence, there are some amazing opportunities that are being developed that will be part of moving forward in your nursing education. And the change in patient care setting is also a critical component. Traditionally, we have educated you in the acute care setting predominantly with limited experience, and even now, most of you think of the acute care setting as the one that you will be practicing in. The reality is then less than 50% of your nurses are in acute care settings. In fact, most of them are by far in primary care settings. And so the opportunity to look at different settings in which education can be delivered, and to think of education, nursing education, not just as a generalist in an acute care setting, but as an area where you can specialize, even at the BSN level, is an important consideration. So moving forward, you will see more and more emphasis on specializations at the baccalaureate level in a variety of different settings. And the generalist approach to nursing will be more in the area of what is the core competencies that nurses need to have. Finally, when we start to look at the online education, this is, again, a challenge that COVID brought us, an unwelcome challenge of pivoting quickly to online. And the interesting thing about that is that it has opened a door to a wide array of opportunities for all of you. One of the things we're looking at is more of a hybrid modality, because we are really concerned about the opportunity for you to interact together like you have today, the opportunity for face-to-face, and yet many of you have contacted us and said, we also like the advantages of having online education and more opportunities to not necessarily drive the freeways, not necessarily be in a particular location, but to be able to take or participate in our courses in a variety of settings. And so over the next years, we will also be looking at expanding the hybrid opportunities, the online opportunities, and both the DMP and the PhD program have moved fully online and are available fully online with intensives to try to create that network and interaction, social interaction as well. Online education is also improving, as you can see with the technology that we had today, with my own being the exception in terms of managing the clicker, right? But overall, the technology we had today meant we could bring you people from Sacramento and in a very real presentation that had them present with us in a virtual reality. So as we move forward with all these changes and looking at nursing education, I want to refocus us on what I think is the core values of our profession, the ones that were established in the past that we want to bring forward into the future. And these values are the fact that, that we have a spiritual foundation and that we view nursing as a vocation. So most individuals who talk about nursing as a vocation talk about it as a vocation because they feel there's intrinsic value beyond compensation and pay for becoming a nurse. And that nurses are really called to nursing. Understanding that compassionate care is a response to suffering that involves a moral choice for us and that is based on our ethical and spiritual values is a really important consideration. And that has always been a core part of nursing. So even as we move forward with the changes in the future that we've discussed, it is also important that we retain that value, that we retain that spiritual foundation and the core value. What becomes really important with that is that as we move forward, service is a core component of nursing. And what Dr. Lydia Garcia just exemplified and Amanda Thurman exemplified was the service component that we build in and fully integrate into nursing at Azusa Pacific University. And that has a long tradition for us. What you see here is two of our former faculty and one who's passed away, who started the Neighborhood Wellness Center in 1996, and it still continues today. And some of you who have taken courses and practice at the integrated clinic at Baldwin Park Medical Center, that is an extension of the Neighborhood Wellness Center that still continues to serve. Many of the outreach that is done at each of our campuses, one of our mandates is that every location, whether it's Monrovia, Azusa, IERC, San Diego, or High Desert, has a service component. Dr. Connie Brem started homeless outreach in 1998. She wrote a wonderful article that says, "Who is my neighbor?" And that has been the core foundation for outreach with the homeless. The homeless shelter has continued to this day and continues in pop-ups in Azusa and nursing education and screening for homeless throughout the area. Here's a picture of Dr. Connie Brem and a picture of homeless outreach in IERC, and it occurs in Monrovia, High Desert, and San Diego. And here's the Monrovia Blood Mobile, and thank you, Dr. Wood, for encouraging that, even in the midst of a pandemic. Global health. Azusa Pacific University has had a passion about participating with global health and international collaboration. And COVID really put a stop to that for 2 years, but we're starting to pick that up. This is clinics in Myanmar in 1993 is when we started our global health outreach. and our service throughout the world. Competencies and technical skills, it's really important that we develop more than that, more than just technical skills, that we develop the heart and the passion for reaching vulnerable populations. Okay. Dr. Catherine Heinlein had a Fulbright in India and did an amazing job of educating the nurses there and some of the faculty there on diabetes and diabetes education. And so she was an amazing representative of the School of Nursing in that area. Haiti, Dr. Pam Cohn is passionate about Haiti and continues to do outreach there and brings students over there and in service and has set up clinics and supported the School of Education, the School of Nursing and Education there. Laos was the other area that we went, and this was in 1997, that we started outreach to Vietnam and Laos, and we continue to this day. We exchange, China's exchange has been operational since 2010, and we have brought scholars here in the leadership program and sent nurses there every year, except for the last 2 years, to study for a semester in China. We also do scholarly exchange in terms of presentations, faculty, and we've had representative from Second Affiliated Hospital in China, Hangzhou, China, come here and present at our research symposium, just as myself and others go back and present in China. In the corner, you see Dr. Poza on her way to Brazil, both student and faculty exchanges in Brazil. The Institute of Health Research, you see Dr. Cheryl Tyson, who is our founding director for the Institute of Health Research. Dr. Tyson retired last year, but that research institute is continuing. It's one of the areas that I will be particularly investing in the future, but it's really important for us to realize that research and new knowledge development is an important component. And so you see the posters from the Research Symposium on that slide, as you've seen the posters today, and that is an important step for new knowledge development for each and every one of you as you start to reach out into areas of understanding and evidence-based practice. 17 years of the Research Symposium. We're a little small today, but a lot of you are watching online. Again, 17 years is an important effort to make sure that you value the development of nursing knowledge and the application of nursing knowledge to direct patient care. And in addition to research and new knowledge, I want to emphasize the importance of theory and nursing theory. But just theory in general. Theory is a part of how we view the world. It's the way we look at things. It's how we ask questions and how we interpret what we see. And so Nursing Theory Conference that we had about 5 or 6 years ago, where we invited nursing theorists from across the area, from across the United States to come and speak and to interact with us, is really an important contribution to our worldview and our understanding of how we design and interpret meaning in today's world. And we also take our doctoral students back to the conferences in Washington, D.C. to have them experience meeting with nursing theorists individually in personal ways. Our Nursing Honor Society is really an important part of our professional growth as well. And so every semester, as we have a new graduating class, we encourage you, everyone who's available and who meets the requirements, we encourage you to join our Nursing Honor Society, because you are then becoming part of a tradition. You're becoming part of an international outreach. You're becoming part of the profession. And you are understanding and accepting a leadership role in the profession. And so we strongly encourage you to come and participate in that. Now I'm going to talk a little bit, I'm going to go back for a second. I'm going to talk a little bit about where the School of Nursing is heading. And this is an important change that you need to be aware of, because we are moving to a College of Nursing in the fall semester. And we've been working on areas of preparation for that moving forward. And so there will be some structural changes in how we organize ourselves. And you'll be hearing more about that moving forward. The College of Nursing will not be just nursing. It will also include non-nursing programs, including public health and healthcare administration. And there is room for other programs that we will embrace, and genetics, genomics is one of them that we will encourage to join within the College of Nursing and to participate with nurses in interprofessional practice. The reason I'm taking this moment to really explain a little bit about what the college structure will look like and what you may anticipate over the next year is because at this point in time, I would also, it was announced yesterday, and we've also been planning for this for a while, my stepping down as Dean of the School of Nursing. I've been in this position for 19 years, and I am just delighted to be able to transition it to a strong leadership team. But there's much change that's happening in the future. The new structure, a new dean, APU is having some challenges itself. They have a new president, and there are changes in faculty, even as we have individuals retiring and new faculty are being brought on. So it's a season of change for us, and it's a season of growth for us, and it's a season of revisiting our core values and looking at what we value and what we want to retain and what we want to promote. So even as we make this transition, I would like to encourage you to maintain a strong commitment to your spiritual foundation, to your spiritual values, to the core values of nursing, to continue to incorporate service in everything that you do, to continue to see service as part of who you are as a nurse and as part of who you are as a Christian. I would encourage you to value knowledge and knowledge development and the application of knowledge in healthcare. And we've had an amazing research presentation today in a variety of ways that really emphasize how important data collection and how important knowledge is when you collect and structure information in such a way that's based on sound evidence, and that you use that to inform your practice. I would also like to encourage you to continue to build on the past, even as we change things in the future, and to draw that continuity of care that we have always embraced, moving it not only into the acute care setting, but more and more into the primary care, the ambulatory care, the mental health, and other global health, other settings where nurses are desperately needed. At this time, I'm going to briefly track you through some of the changes in the structure, and then, and so you have a sense of when this starts to happen over the next semester or two, that what this all involves and how we are guiding the process. So the college structure will initially, over the summer, start to move instead of into schools, into divisions, which will ultimately lead into schools. So right now you see on the slides the division of associate deans heading an undergraduate school of nursing and a graduate school of nursing, initially division, ultimately a school. You'll see the associate deans that will provide support to the process, and the director of operations. So what will this consist of? Well, the Division of Undergraduate Nursing Studies, headed by an associate dean, will incorporate our traditional undergraduate program, 4-year, our BSN transfer program, and our RN to BSN program. Initially, the pre-licensure component of entry-level masters will remain there, but it will be moved, after a year, will be moved over to the graduate school. The graduate programs will be entry-level masters, BSN to PhD and DNP, MSN, non-APRN, and MSN APRN, and then the DNP postmasters and the PhD postmasters. The non-nursing programs currently will be public health, the healthcare administration track, and we are proposing adding a physician assistant and a genetic counseling component to those programs, and there may be others moving forward. Program support will be in 4 areas. One of them will be the Associate Dean of Faculty Affairs, which will really focus on faculty development. With a lot of new faculty, we are actively engaging into a very systematic way of faculty development in order to bring our new faculty up to speed. The Associate Dean for Assessment, Accreditation, and Evaluation will be instrumental in making sure we stay on track in terms of all of our accrediting bodies and BRN approvals and so forth. But more than that, will be very instrumental in terms of gathering the data and the information that's needed for us to evaluate and change or correct things that we need to improve, to highlight the things that are going well, and she will be involved, or he will be involved in innovation. The Associate Dean of Student Affairs will continue to be actively involved in student affairs, in Faith Together communities, in student support services, and building student services in the School of Nursing. And then the Associate Dean of Research and Grants, who you have met, which is Dr. Teresa Dodd-Butera, will be very involved in continuing on with research grants activities, the Research Symposium, Distinguished Lecture Series, in those areas. So essentially, the structure of the School of Nursing will be 3 divisions, which will ultimately result in a lot of opportunities to integrate faculty, curriculum, and learning opportunities at the pre-licensure undergraduate level, the same at the graduate level, and then also in non-nursing programs. Operations and support will continue with the Director of Operations, and that will involve the budget, human resources, facilities, technology, and communication. Experiential learning, which all of you have been very involved in, which is virtual skills and simulation, will move under the Associate Dean of Faculty Affairs, and she will provide direction to that. And so if you take a look at that earlier slide, you see what that would look like. And then finally, my timeline for transitioning. We first started talking about the transitioning to a college several years ago, but more closely, we did the draft proposal on March 11th. April 8th, we had WASC visit us, the university, for approval. And today, we have announced to the university and to the School of Nursing and to all of you the transition of the dean. And then July 1st, it's my pleasure to introduce to you Dr. Renee Posa, who will be interim dean and who will take over July 1st. Now, I found this picture. When I was going through some of those slides. And this is your dean history. So Dr. Della Blackburn is the dean that's on far, whatever side that is, right? Dr. Della Blackburn, I think, was dean in 1989, 1990. Dr. Posa and I were trying to remember back that far, right? Dr. Rose Liegler was the dean after that, and she's in the center. And that's a very young picture of me. I was not dean then, I was a faculty member, but it was really interesting that we were all three together providing guidance and leadership to the School of Nursing. So we have a long history of being present and guiding the school forward. And Dr. Posa is going to take the next steps to move forward with the guidance to both the college and to some of the changes in curriculum that we're facing. And I know here we go. Let me just say a little bit about Dr. Posa before she comes up. And she will say a few words, and then we will wrap up with benediction and ending the research symposium today. But Dr. Posa was one of my students. She was in my research class. And when I was working on the High-Risk Infant Project, which is a project that I've had for about 40 years also. Started that early at Cal State LA while I was still teaching there. Has continued throughout the years. Some of you may have had experiences in there if you were pre-COVID. We did have to scale way back during COVID. But the High-Risk Infant Project was a project that followed at-risk infants after they were identified in the neonatal intensive care unit as needing follow-up after discharge. Most of these were extremely premature infants initially, and ultimately that project was expanded to individuals at risk because of family substance abuse, mental illness, and so forth. I gathered a lot of data and had a lot of data available, and so in the research course, our first introduction to research was looking at high-risk infant data and drawing conclusions from some of the questions that were asked in relation to this. This was at the undergraduate level. So she and I have known each other for many years. She has served as associate dean in the School of Nursing for for about the 17 years that the research symposium has been going. She is currently the Associate Dean of Academic Initiatives and Innovation, and she's a full professor. She's chair of the School of Nursing Curriculum Committee. She earned her BSN and her MSN at APU and her PhD from University of California in San Francisco. She maintains an active practice as a nurse practitioner with the California GI and Liver Centers, and she also has her research in that particular area. So it's with great pleasure that I asked Dr. Posa to come on the stage, give us a few comments, and transition over the next few months to her. And if you need to slide, it's this one. I was clicking the wrong one.
Don't go too far. That was a lot. It's been many years of I together, Dr. Lesh and I together. As she mentioned, all the way from the undergraduate program with the BSN. And so those students out there, get to know your faculty. You never know where they're going to take you. I think Dr. Garcia said it, Ursary Garcia said it the best when she said you're going to get stretched, right? Whether you're in your bachelor's program, your master's, or your doctoral program, we all have mentors and sponsors that stretch us beyond places we ever thought we would be. So I am deeply honored to be asked to serve as the interim dean of the School of Nursing. And I hope I can do this without crying, because we've known this was coming, but when it finally gets announced and the things get put in writing, it seems real. And so we will continue with the strong legacy here at the School of Nursing at Azusa Pacific University. I am so honored and privileged, where we are committed to nursing excellence and the impact that the School of Nursing has on the patients and the families we serve, the researchers we prepare, and those we collaborate with. And I look forward to continuing to graduate nurses prepared to be difference makers in the workforce, both regionally, state level, nationally, and globally. We certainly know the impact that our School of Nursing alums have on not only the nursing profession here locally in the Southern California region, but all across the world. We will continue to establish academic practice partnerships and look for ways to bridge gaps in practice and policy issues in order to impact diversity and health equity. The faculty, staff, and leadership team within the School of Nursing is excited and energized to find ways to celebrate the contributions of Dr. Lesh. And those were just a few on those slides today, and I hope over the next few months we certainly can find multiple ways to celebrate all the significant things that you have done for the School of Nursing as you has moved us forward, and we will continue to move forward. I'm excited to work with a very committed nursing faculty, both our full-time faculty and our adjunct faculty. We have some of the best professors here that are so committed to not only your education as students, but the work that they do. It was an honor to hear from some of our faculty today and some of their passion, areas of passion in the clinical work that we do. And I'm honored to work with a great leadership team as we move forward in this time of transition. I know we can rise to the challenges, and I look forward to meeting some of our opportunities that we have ahead of us. Both in the work with our alumni as well as in students and the faculty and staff that we serve. So now let me I'm going to transition us into the next section, and let me do a little summary closing as we close the day. It's been really fun to be back in the room and see each other and participate and have conversations. I always enjoy days like this because it's faculty and students interacting, but I see our clinical partners here, our research partners here. Thank you for those of you that submitted poster presentations, and congratulations to the award winners. And most of all, thank you to the research committee. I see some of them out here that have put this tremendous day on. We really appreciate all of the hard work and the efforts that you've put, not only into making this event beautiful, but inspiring and scholarly all at the same time. So thank you very much. Let's give them a round of applause. So our theme, creating a culture of health equity. Our speakers have shown their expertise in several areas. We learned early on this morning about environmental health equity, where we reminded us of our homes, right? Our in utero home, our earth, our homes, the place we live. And I think Dr. Butera, I'm going to remember the tell one model, right? So I urge all of us now, we're going to tell others what you learned today. I hope that you were inspired by some of the things that you heard, that you are asking yourself new questions and looking for new answers and ways to solve the problems. We heard from the Biomonitoring California program. Now, I am going to go home and look at my skincare creams, right? And I might have to be throwing some away. I'm not sure. That was some interesting information that I think made all of us kind of rethink some of the things that not only we consume, but the environment that we're in and even the air we breathe. So it was interesting and maybe concerning for us to see some of the California issues compared to, for example, the national NHANES data. And then we were reminded again to do one thing at a time, right? So not to be overwhelmed, but we're going to do one thing at a time. And then Dr. Lerner's, thank you so much for your All of Us presentation, where we learned the benefits of the large databases, especially on precision medicine, and the impact that it has on our treatment, our medications, our genes and the biomarkers, and all of the information that we'll be able to glean from this. And it's really stressed the importance of our studies having diversity in our participants and the impact that those results and recommendations will make from those studies. And then we moved into talking a little bit around food insecurities. And when I learned about the SNAP challenge, and I guess we'll have maybe an APU SNAP challenge because that's our student nurses of Azusa Pacific. And we can have our challenge to see if we could do that. And so thank you for that presentation. And the impact of the food distribution sites in the high desert area and the rural neighborhoods. And then your online presentation will touch on homelessness. And finally, our dean, Dr. Lesh, has highlighted what needs to be preserved from our past as we transition to a strong future. Part of the past that needs to be preserved is a research legacy that dates back to the establishment of this day in 2005, where Dr. Lesh was installed as a dean here at the School of Nursing and at APU, and the 17 years that have followed with the research symposiums. Dr. Lesh has led the School of Nursing into doctoral programs, the start of our PhD program, and then our DNP program, and taking many of our programs online. She has been the force behind a lot of the grant funding that we've received within the School of Nursing, which has benefited many of you in this room, both in our faculty nurse loan forgiveness programs, grants that supported mental health work, psych mental health nurse practitioner programs, and the BWET grant. I think of the ANEW grant, which works with nurse practitioner students in FQHCs, and I could go on and on and on. So we look forward to Dr. Lesh not retiring, but to continuing with us in the School of Nursing with the emphasis in working in our Institute of Health Research and continuing her work in grants both to fund programs, research, and benefit our students. So at this time, I would like Dr. Lesh to join me, as well as Brent and Valerie, Dr. Smith. We have a special presentation and announcement.
I didn't realize it would be so difficult.
You can change your mind. Dr. Lesh, because of your strong commitment to research and strong leadership, we have established a new official name for the future research symposiums. From this point forward, we will hold the annual Dr. Iota Lesh Research Symposium.
Thank you. I'll tell you a little story. When I started my doctoral education many years ago, there was, my father had been very instrumental in encouraging me to go into education. I came here from Holland. We, as a family, immigrated and didn't know a word of English. In fact, when someone talks about the importance of understanding what's happening, I remember the moment I was in church, the moment I first understood a word of what the priest was saying, and it was like a miracle, you know, aha, the lights came on, I knew what he was saying. It was so important. But he always emphasized nursing education, and so when I started my doctoral program, about a month and a half before I started, he died, and it was such a devastating thing for me at the time, and I thought to myself, I can't do this, I can't continue on with my doctoral program. And then I thought my father would have wanted me to continue on in spite of that, and so I did. But as a result of that, when I graduated, I readopted my maiden name, Tulliners, which is a little bit more difficult. And so in some ways, having the research symposium named Aya Tulliners Lesh is a tribute to my father. Thank you.
Let's close in prayer. Dear Heavenly Father, we thank you for the opportunity to come together as nurses, scholars, leaders in the profession. Thank you for this wonderful day that we have learned much, have many challenges, and have had significant inspiration into the things and the ways that we can impact the world, and not only for their health, but for the good of all people. I ask that you continue to bless the School of Nursing as we move through this time of transition. Be with the leadership as decisions are made. Give us wisdom so that ultimately we are moving forward in the path that you've already established and you know the way for us to go. I ask blessings, particularly on students. I know this is coming to the end of the semester, and some of them have finals approaching. Some are in finals maybe this week, and have some significant things to finish up over the weekend as they move forward. Be with them, keep them safe and healthy, and able to finish strong. And many of them will move right into semesters that start again the following week. So continue to be with us and bless us. Now finally, may the road rise up to meet you. May the wind always be at your back. May the sun shine warm on your face. The rains fall soft upon your fields. And until we meet again, may God hold you in the palm of his hand. Thank you, and you are dismissed.